Good afternoon and welcome to bill hearings. It is 1 p.m. You know, we start on time. I'd like to thank all our committee members for all your work. We're almost halfway through session. And who's counting? No one's counting. Welcome to the Health and Government Operations Committee. I'm your chairman, Jocelyn Pena-Milnick. I'm joined by my vice chair, Ariana Kelly. This is our first session back in person since 2020. So I ask for your patience if we encounter any technical or streaming issues. Please set your electronic devices to vibrate and don't hold conversations in the committee room while testimony is happening. If you need to, please go outside. We're going to hear from the bill sponsor and the bill sponsors panel, followed by an all in-person witnesses, favorable with amendment, and unfavorable, then all virtual witnesses. The same thing, favorable with amendment, and unfavorable. The bill sponsor testimony is not limited, but please don't take more than 10 minutes because then I'll have to stop you. While all witnesses will have 2 minutes to provide testimony, the timer does go off. Please be respectful and wrap your thought once your time has expired, because then we're here very late. Last night we were here till like 7:30 or so. Please adhere to our usual committee rules of 1 question and 1 answer from the panel. And for the committee, respectfully, I'm going to be stricter about that because we're going to get very busy with the following 40-something days. So please, you know that we do a lot of the work here in subcommittees, and we can also seek information offline as well. Please keep your questions brief as well. Go straight to the question. Members of the public will be able to view the live stream of this hearing on Maryland General Assembly website and YouTube. Today, we're going to hear the following bills. Before I go there, I'd like to remind the people in the gallery, we want to thank you for coming. You're welcome. This is your home. But we would like you to treat this like your home. There's no food or drink allowed in the gallery. Yesterday, staff had to stay last night and clean up a lot of food and drinks and things that were spilled on the rug. And members, please, if you put something, make sure it's in the garbage, that it doesn't spill, because they had to do serious cleanup in the committee room last night. And they're really busy. So if we could just treat it like we treat this at home, okay? Please be mindful of dirty dishes and trash. Avoid throwing liquids in the trash. This is a shared space, so please be respectful of all of us by keeping it tidy. The following bills are the ones that we're going to hear today. We're going to start with House Bill 614. Delegate Collison, you could start. Just go ahead and sit and bring your panel, please. Then followed by by House Bill 1145, House Bill 583, House Bill 811, House Bill 490, House Bill 489, House Bill 814, and the last bill of the day, House Bill 588. Today, we're also joined for the first bill, the House Bill 614, Department of Aging Dementia Care Navigation Programs. This bill is jointly assigned to Health and Government Operations Committee and Appropriations. Will you please introduce yourselves?
Sure. I'm Delegate Emily Shetty, Vice Chair of the HSS Subcommittee on Appropriations.
Thank you and welcome.
Delegate Jim Heimel.
Thank you. We really, and I know Delegate Henson was going to come, but she has to take care of a very important personal matter. So welcome to our committee, and you're also welcome to ask questions, okay? Just to let me know, make sure I know as well. Delegate Collison, how are you?
I'm pleased to be the bookend today, the first and last. I think it's more than one dinner that I owe the committee, Madam Chair.
Last night, after everyone left, staff and I, we usually have to stay, go through the bills. And I said, make sure that you contact Delegate Collison and Delegate Kerr because they owe us dinner. So you will be contacted by staff. And make it good, like not just pizza, okay?
Oh, no.
Although pizza is good. Go ahead, you can get started.
Thank you, Madam Chair, Madam Vice Chair, members of the committee, and welcome to the first bill of today. It is the Department of Aging Dementia Care Navigation Program. So this is a bill that is going to be needed more and more as those of us in the baby boomer generation age into our 70s, 80s, and 90s. And the way that this bill addresses the needs that we are experiencing to this largest generation of population generation that we've had so far in this country, by requiring the agencies of aging in each of our localities to come up with a program, a navigation program, that helps not just folks with forms of dementia and Alzheimer's, but their caregivers. And that's a really important part of this bill. It was introduced last year, but it really wasn't ready for prime time. We've done a lot of work during the interim. I've had a number of meetings with advocates. I think it is ready. I know it is necessary. So before 2022, we outreached to 19 of the area agencies on aging. Since then, even more. And we have taken their information, we've listened to their concerns, and we've made changes in the bill that address them. So what does it do? It removes the requirement that, one of the changes from the bill is that it removes the requirement that the agency actually hire a coordinator for the work, because what we want a locality to be able to do is design the program that meets its culture, needs, and the folks it's serving. So we thought you can take the money that you were going to put into a coordinator and put it into other aspects of the program. It provides more resources for county aging departments, and it does this based on need, not on population. In the past, we've done a lot of granting on funds like this to just based on population, but the percentage of need in, for example, in Washington County might be higher than the percentage of need in Montgomery County. So in terms of the allocation of funds, it's going to be based on what folks need. And this allows the locality to really define the program. We believe that this is one of those bills that's designed not to leave anyone behind. And it does this by making sure that there's supports and assistance for those who have symptoms of dementia that interfere with activities of daily life. You know, we all know, I would suspect that we all know of someone who is a caregiver for a parent or an aging loved one who may be exhibiting signs of dementia. We may know the experience personally. I guarantee if you haven't experienced it or haven't seen someone who has experienced it, you will. And today you are going to hear from folks who have had that experience. You're going to hear from someone who spent $1 million of her own money and her parents' money in order to meet the needs of her parent. Being the caregiver, I am a caregiver, which is why I'm choking up a little bit here. But it takes a lot out of you, both physically and emotionally. And it wears on us to see our loved one decline. They might refuse to eat. They may get physically angry. My mom never yelled at me until the end of her life, and it was just part of what the aging process that she was experiencing. They have more trouble communicating. They may wander around. And as it wears on us, it compromises our ability to do our work, to sustain ourselves in our jobs, and we spend more and more time doing it. But Maryland, unlike 11 other states, has no dementia-specific funding to help caregivers who devote their lives, their time, their energy, and their emotions to people who suffer from this disease. So I looked at the chart today, and so far, 1,275 bills have been dropped in the hopper of the House. But this is the only one that brings financial resources to the Maryland Department of Aging. Right now, we estimate that there's about 242,000 dementia caregivers who are literally providing that service with no supports, no help. And it's, affecting their quality of life as well as the quality of life of the people that they serve. So you're going to hear from a number of people who have experienced it, and then folks who know about programs that are working. And I want to make sure that as you think about this bill, it is about putting funds where they are needed. It's tough for us. I know when we see a sizable fiscal note, it makes us nervous. But sometimes we need to make sure that the needs of our constituents are met, and to whatever degree we can do that. So with that, I respectfully ask for a favorable report on HB 614, and I will turn it over to my panel. Thank you. So
Who will
wants
be
to go
next?
first? You want to go first?
Good afternoon. My name is Jennifer Eastman, and while I am the Director of Community Living Policy at the Maryland Department of Disabilities, I am testifying today as the Chair to the Maryland Commission on Caregiving. My testimony reflects the position of the Commission and not the Department. Serving as the voice of the caregiver, the Maryland Commission on Caregiving is charged with recommending policies that positively impact family caregivers, soliciting and responding to their concerns, and acknowledging their contributions. Anecdotally, access to resources and reliable information has time and time again been identified as one of the largest hurdles family caregivers face. HB 614 proposes to meet that need in a very meaningful way for people with dementia and their caregivers, which is why the Commission supports it. There are 19 area agencies on aging, or AAAs, throughout the state that receive federal funding for a multitude of programming, including caregiver support, information and referral services, and application assistance for state and federal programs for older adults and people with disabilities. While many AAAs are already doing impactful work specific to dementia, including outreach and education, evidence-based caregiver training, and organizing support groups and memory cafes, this is not consistent across the state, and most are utilizing existing monetary and staff resources to conduct them. With a mandatory state appropriation that trickles down to the local AAAs and a statewide coordinator within the Department of Aging, consistency of quality can be achieved regardless of the county in which one lives. Additionally, the Dementia Care Coordinator can work with the Department of Health's current efforts and resources and with the Virginia Jones Alzheimer's Disease and Related Disorders Council to achieve the goals set forth in the Maryland State Plan to address this disease. Maryland has been a leader in its Aging and Disability Resource Center infrastructure, yet it lags behind 11 states for this specific appropriation. HB 614 is an investment in the aging population and their caregivers, which is why the Commission urges a favorable report. Thank you.
Next, please.
Andy, you go.
Dear Chair Pena, Melick, and the rest of the committee. My name is Andy Lepore, and my dad was diagnosed with moderate Alzheimer's at the end of 2021, and I'm his designated caregiver. When I first found out about the diagnosis, I was completely overwhelmed, trying to find out as much as I could about the disease and the effects on the person diagnosed. To my surprise, there is not a lot of information out there to be able to get help in Maryland. This is a disease that affects more than just the person diagnosed, but also the caregivers. We have to be strong and mentally prepared for the days, months, and even years to come. My dad is still able to live a normal life right now, but I'm trying to navigate this knowing I will eventually have to stop working to care for him. You grow up always depending on one or both of your parents, knowing that one day they may need to depend on you, but you don't realize that they might not be able to recognize you at some point, even though you know who they are and how much they love you. This will be a journey for both of us to go through together. Unfortunately, we run into some bumps in the road. His neurologist wanted him to get into a study for people with Alzheimer's, and he wasn't a candidate because he has regular insurance and not Medicare Part B. This saddens me, as you have a person willing to help further development of hopefully a cure one day and is rejected because of insurance coverage. He was introduced to another study. We brought home a device to measure his brain waves, and by the time we got home, he was called and told he wasn't a candidate anymore due to the fact he hadn't deteriorated enough. This whole thing, as my dad's caregiver, is confusing. I could really use some help. My father is one of the most selfless people I've ever met. He only wants to help and is being denied on all fronts. I feel the disappointment in his eyes and voice when he hits a setback. There needs to be more education and research for them and us as caregivers to be able to cope with all of this, for our emotions and the person diagnosed with this disease. It is very heartbreaking to see the one person in your life that has been the strongest person you know slowly disappear, one moment at a time and no way to help. I have looked all over the place for real information. I found was with the Alzheimer's Association. We as a state need to do more for our fellow Marylanders to get educated about the disease and help the caregivers and give them a true support system. Thank you for your time and listening to my dad and I's story.
Thank you for sharing your stories.
And-
You know, we appreciate it.
And her father is here today,
Right there.
right there,
Hi, how are you?
in support of this bill.
Wonderful. Great.
Chair Pena-Melnick, my name is Brenda Freed, and I'm here for the support of House Bill 614. Shortly after my dad passed away unexpectedly, I remember my mom saying to me, "Your dad remembered what I forgot." That was a sentence that changed my life. It was then that I realized that her forgetfulness was a little bit more serious than I realized, and I wasn't going back to Louisiana. It was time to come home to Baltimore and take care of my mom. It was as if she turned off the lights after he passed away and her dementia escalated quickly. For me, I had to turn my back on my corporate career of over 30 years, where I'd risen to the level of Vice President of Marketing during my highest earning years. It was now taking my mom to her many doctor's appointments, ordering, monitoring, and dispensing her meds, paying her bills, doing her grocery shopping. I'd take her out to eat, go shopping, watch a movie on TV, whatever she wanted to do. My objective was that she didn't have to worry about anything. I just wanted her to be happy. I couldn't take on a traditional job, as I would have had to take off too much time every week to care for her. I needed the flexibility to work around my mom's schedule, so I did do some consulting. Chair Pena-Melnick, I couldn't spend enough of the right hours building my business. I also became a real estate investor, but working with contractors was beyond challenging, and ultimately they destroyed my business and cost me many dollars. The financial toll on me personally was the loss of, I'm at over $1 million in income, as well as having to take distributions out of my IRA, putting any thinking of my own retirement far, far in the future. And I also think about my own future. My grandmother had Alzheimer's, my mom had Alzheimer's. What's going to happen to me? Both my grandmother and mother had children who loved and cared for them. I don't have children, so I'm going to need to be prepared if, God forbid, I fall prey to this horrible disease, to arrange for my own care. But I'll tell you that the 7 years I was my mom's caregiver cost me dearly financially. But would I do it all over again? Absolutely, because she was my mom. Thank you.
Thank you for sharing your mother's story.
Thank you.
Good afternoon.
Good afternoon.
My name is Pamela Talley, and I live in Prince George's County with my husband and son. We also have an adult daughter who recently graduated from a Maryland Public University last spring. As you're aware, Maryland has over 200,000 dementia caregivers. I am just one of many, yet I am here representing.
Excuse me, can you put the microphone a little closer?
Okay, thank you.
Thank you.
I am here representing my experiences and the experiences of dementia caregivers across the state of Maryland. When I reflect on the day I realized something significant was wrong with my husband, it couldn't have come at a worse time. I had a surgery scheduled that day, and the pandemic protocols dictated I come along for the procedure. After surgery, the doctor and nursing staff were unable to reach my husband. This was uncharacteristic of him. He's a loving and dependable person. Strategic thinking led the staff to retrieve my phone from security, search my contacts, and identify a local relative to drive me home. Later, I would learn that my husband was grossly disoriented to time and had made a poor decision to turn his phone off on the day of my surgery. This led to formal testing that diagnosed him with vascular dementia. 1 year later, more detailed diagnostic testing would lead to an additional primary diagnosis of Alzheimer's disease. This was devastating news to our family, as I am already the primary caregiver to my son, who has a developmental disability. After the diagnosis, I turned my attention towards needed resources. What I learned is that there are waiting lists, underfunded programs, and a lack of needed resources. As a caregiver, I desperately need someone who can partner with me to identify specific priorities for my family. This bill will create a dementia care navigator program to help me and thousands of families across the state. I am confident that you will agree with me that dementia caregiver support is critical to the foundation of so many families across Maryland, and funding to help seniors age in place is a priority. Thank you for this opportunity to share my experience as a caregiver. I am a proud mother, spouse, and Marylander. I believe this state desires to support caregivers and their families impacted by Alzheimer's disease, because this journey I am on is hard. I'm available to answer any of your questions. However, my question for you is, can I count on your support for this bill? Thank you.
Thank you for each and every one of you for sharing your stories with the committee. Delegate Collison, you have a Terry Johnson?
She's virtual.
Okay.
Yeah, she's here. Is she there? Oh, she's here. Oh, I'm sorry, she's here.
Yes, may I have Terry Johnson, please? Will you be so kind and come up? Thank you very much. You do have a virtual one, but that's Ms. Halima Amjad. My pleasure. Go ahead. Good afternoon, ma'am.
Good afternoon. Good afternoon, Madam Chair and members of the committee. My name is Terry Johnson. I am a member of the Maryland Commission on Caregiving, as well as a previous caregiver of my mother, who had vascular and Lewy body dementia. I'm here to testify why I support HB 614. It is my firm belief that its passage will provide the desperately needed assistance to dementia caregivers. My mother was referred to Johns Hopkins Alzheimer's Clinic by her primary care physician. She was tested and diagnosed. Neither her primary care physician nor her neuropsychiatrist provided me with any sources of support. I was lost and overwhelmed. I neglected my own needs, as is common with caregivers. I watched as this horrible disease ravaged her brain, and I slowly lost the mother I knew as she slipped away into a world far from me. Grief was daily. This legislation will create an outreach at each local Department of Aging to coordinate, support, and provide assistance for dementia caregivers that I did not have. Passage of this bill will be the link that will now connect all available sources to help sustain dementia caregivers during this difficult journey. This bill will also establish relationships with healthcare providers, as they are our first line of communication after diagnosis, which is something that I did not have. Their knowledge will then guide dementia caregivers. This is why I support HB 614. Thank you for affording me the opportunity to testify today.
Thank you for sharing your story and being with us. Are there any questions for the sponsor and her panel? First, I have Delegate Kaiser, followed by Delegate Shalega.
Thank you, Madam Chair. My question is for you, Delegate Cullison. So while you get near the mic, I'll ask the question. I looked at the fiscal note, of course, and I think we should certainly look at things more than just monetary costs, but the social benefits and what values we have as a society. But going back to the financial aspects, I also know that our fiscal notes don't account for any indirect costs and benefits. So I wanted for you to chance to address or share what indirect benefits or long-term cost savings you think would come from this legislation.
Thank you, Delegate, for the opportunity. So right now, again, we spend, our constituents, our residents are spending a lot of time, energy, money on navigating a system independently. So there's a lot of time lost, a lot of income lost, and a lot of care loss because they're not able to find access to the resources they need to support their loved one. We can regain that economically in our communities by making sure that that system is clear and that folks can be pointed in the right direction for supports. And that's why it's so important that each community, each locality define its own programs, because they know what the resources are and that exist, and they can point people in the right direction, and they can also determine gaps in their care. And so that's probably another good unintended consequence or benefit, is looking at where we have gaps in this kind of care as this population increases. So thank you, Delegate.
Delegate Szeliga.
Thank you, Madam Chair. Thank you for this bill. This question is for Delegate Cullison. So I'm on the Maryland Commission on Aging, and we've talked about, these and other programs. So I'm wondering why we don't have any support from the new secretary. Is it because of a transition from Rona Kramer to Carmel, or where is the Department of
It was when we were working on this, it was transitional. We just hadn't been able to reach out yet. So I need to do that. Thank you.
I would be happy to help facilitate that.
Okay.
She's wonderful. The new secretary is really nice.
Okay.
She was on the commission.
Thank you.
You want to give her a call, let her know? Thank you. All right, I love it. Delegate Hill.
Madam Chair, and thank you, Delegate, for bringing this bill, and thank all of you for testifying today. So did you get a chance to read? Delegate Cullison?
I'm sorry.
It's okay. Did you get a chance to read MoCo, Montgomery County's, and did you have a?
I do,
Okay,
I do.
They list some concerns, they want it to be voluntary, and I guess the question is, as you answer those concerns, if this is the right program, why only for dementia caregivers and not for caregivers more broadly?
So first, let me respond to Delegate Szeliga. Apparently, our advocates have spoken with the new secretary, and I've not been updated, so we will get that information. Now to you, Delegate. So one thing, the first question they ask is, why shouldn't this be voluntary? And I think the response to that is mandates are always difficult. So anytime, and we know that here, anytime we mandate something, there's pushback on that. But we also know that there's not enough support in these localities necessarily, and that there hasn't been an analysis, a deep analysis of how to navigate the system, as I was saying to Delegate Kaiser. So we believe that this funding directed for this particular need is, would incentivize them to make sure that the program is incorporating all of the resources that they need. So that's part of it. Why just dementia and Alzheimer's? From my perspective, it's financial. I mean, this program alone, we're talking about $2.4 million, and Montgomery County is asking for more. So just for Alzheimer's and dementia. So we were trying to focus on the population that is one of the most challenging populations because of the concerns about, loss and wandering and, the danger to themselves sometimes. So I think that's a big part of that, or why we chose that. They are also concerned that it will cost more money for caregivers or for cognitive assessments. I'm willing to talk about how we narrow that, but I will inform folks, since I am subject to this, Medicare requires an annual cognitive screening. And it's essentially a 6 or 7 question test that you do. The one is that I always remember now, I'm going to tell you 3 words. I want you to tell me what those 3 words are. And 20 minutes later, they say, and what were those 3 words? So, so it's not a difficult screening. Anyone can do this screening. You know, it would be very easy to train existing staff to do the screening. So I think, you know, and we can talk about perhaps relying on the Medicare annual physical to make sure that at least those over 65 are getting that support. And then again, it's you know, it's a financial issue. They're saying it's, you know, they would need more to do what we're asking them to do. And I don't disagree with that necessarily, but I'm trying to give them a start in this work.
Vice Chair Kelly.
Thank you, Madam Chairman, and thank you, Delegate Cullison, for this bill. And I echo everything that you just said as a Montgomery County delegate. My question actually, though, was for Ms. Freed. Your testimony was really moving to me, and I have been down this road with my grandmother and my father. And so I was thinking about a conversation I had with Governor Moore this morning. We had a meeting of women legislators to discuss women's issues, and the point he made was that these women's issues are economic issues, that the economic issues cannot be separated from women's issues, and your story really conveyed that to me. So I would like to hear from you, sort of as a follow-up to Delegate Kaiser's question, if we had a program like this in place, do you think it would have helped you better balance and navigate your caregiving responsibilities and potentially mitigate the devastating financial impact on your personal life and your future need to pay for your own caregiving? Because, of course, this is multi-generational and cyclical.
Yes, I do. I actually more internalized and really didn't reach out and said, she's my mom, I've got to take care of her. She was down at Hopkins and Bayview in that Alzheimer's department, and they were very helpful, but when it comes to resources, you really don't get a lot of help. Of course, I wished I had reached out more to the Alzheimer's Association. I think from maybe having some care come in and take care of her, just to give me a break sometimes, and at a certain point, we did bring in 24/7 care, but I was still the one that beat the ambulance there all the time, at whatever time. So, you know, even though at the point in time when it got to where I couldn't take care of her anymore, it was still a 24-hour worry. And I still had to stay in the state of Maryland because my career was actually elsewhere. So, so it impacted me throughout the rest of her life. Do you make up $1 million lost in income? No, you don't do that. And I guess I wasn't really willing to say what kind of job would I take, and I was looking more entrepreneurially. And, you know, consulting was not enough to fill that gap. But I had to be able to do things that were not in those 8 to 5 hours, and that I could work anytime I could. So that was really my challenge, is finding ways to provide for myself in the midst of all of that, in addition to taking care of my mom.
Thank you very much.
Seeing no other questions, thank you so much to this panel.
Thank you.
Thank you, Madam Chair.
My pleasure. Next, I have Eric Colchamiro. And I have actually one virtual witness as well. But Eric, good afternoon. And you can get started.
Chair Pena-Milnick, Vice Chair Kelly, members of the committee, thank you for the opportunity to testify here today in support of House Bill 614, which creates an outreach program for for dementia caregivers at each of Maryland's local area agencies on aging. This legislation is necessary because dementia caregivers need the help.
Just give us your name for the record, Eric.
Oh, Eric Colchamiro, Alzheimer's Association. Okay. Caregivers need the help. Dementia, and there was a question as to why dementia. Dementia is a disease that gets progressively worse. We have Dr. Amjad, a primary care physician and a specialist who can speak to that in detail following me. But 68.8% of our caregivers have chronic health conditions. 27.7% of our dementia caregivers have depression, and 13.6% of them are in poor physical health. Yet statewide, we have $0 in dementia-specific funds to help them, unlike 11 other states. We are leaving Maryland residents behind, and as Ms. Johnson said so in such a moving way, caregivers are neglecting their own needs. This bill has been developed over the interim after listening to the state and our counties. There are caregiving statistics, and there are the people behind those statistics that you've heard from today. And there is the State Commission on Caregiving who has spoken from an overarching perspective as to the need for coordination amongst local dementia caregiving initiatives. The need for people who are living with this disease right now is urgent. I'd just like to finish by noting the money component to it. There was a question on money. I would love to come back in another year and ask for $5 million. I think, like we did with 988, appropriations can be increased over time. This bill starts with an average of over $100,000 for each local jurisdiction. That is in line with Wisconsin, who has created this program over a decade ago, and it is in line with Anne Arundel County, who has this program now. I ask for a favorable report on this legislation. Thank you.
Thank you. Are there any questions for this witness? Seeing none, thank you, Eric, for your testimony, and thank you for the work you do. You do great work.
Thank you.
Next, we have Halima. Hi, how are you?
Hi, can you hear me okay?
Yes.
Good afternoon. My name is Dr. Halima Amjad. I'm providing testimony in favor of this bill as an individual who has intimate knowledge of dementia. I'm a geriatrician researcher at Johns Hopkins, where I care for people with dementia and their families at our memory center and lead research on dementia diagnosis and support. I serve as chair of the Maryland Virginia I. Jones Alzheimer's Disease and Related Dementias Council, and most importantly, I've lived dementia through my father, who had frontotemporal dementia for 13 years. Dementia and dementia caregiving are unique in their complexity and burden. It's usually diagnosed later than it should be, and after diagnosis, most families don't fully understand what to expect, now or in the future. It's not just memory loss. It affects other areas of cognition and brain function. It inevitably involves functional decline, with help needed for complex tasks and eventually even for personal care. Behavioral changes are common. Unique to dementia is a loss of autonomy and, as the condition progresses, complete dependence on others. Individuals and caregivers often have medical needs, not just for dementia, but for other health conditions as well. But their needs aren't just medical. There are educational, emotional, behavioral, social, financial, and physical needs that far exceed what health systems and clinicians can provide. Families need to build a network of support, yet overwhelmed caregivers are expected to coordinate that network themselves. Care coordination available to all Maryland dementia caregivers is an important step to supporting this invisible army. How we currently address complex dementia needs within our healthcare system is fragmented, confusing, and inadequate. Care coordination can address these needs and bridge medical, community, and support resources. In my clinic, I have many caregivers who would benefit from care coordination. Rather than simply validating their struggles, I look forward to having a service I can link them with as they navigate the most difficult of journeys. Thank you for considering this bill.
And thank you for being with us today, and thank you for sharing your story with us. Are there any questions for this witness? Seeing none, thank you so much for being with us and for taking, the time to wait for your testimony. This actually concludes the bill hearing on House Bill 614. I would like to thank, on behalf of the Health and Government Operations Committee, the Appropriations Committee, for being with us today. You're welcome anytime, okay? Thank you. Next, we are going to go on to House Bill 1145. Delegate Riley, if you have a panel, will you be so kind and bring them with you? It is titled Health Insurance Hearing Aids for Adults Coverage.
Thank you, Madam Chair. I believe I'm a panel of one.
That is Delegate Riley.
So it should be.
You are enough.
Thank you. Okay, I've only been in this committee since I've been elected one time. I think that was like back in, 2014 or something. You scared me to death. I never came back. But anyway, here I am, actually on the committee, so thank you very much. One of the best committees. So anyway, good afternoon, Chair Penna-Melnick and the members of Health and Government Operations Committee. For the record, I am Delegate Teresa Riley, District 35A from Cecil and Harford counties, here to introduce HB 1145, Health Insurance Hearing Aids for Adults Coverage. I'm going to go through a little bit of history to show you where I'm going. So anyway, Maryland carriers that provide coverage on the Maryland Benefits Exchange follow the Affordable Care Act, ACA, guidelines, which include the 10 essential health benefits, EHBs, that must be included in the state benchmark plan and any other benefits mandated by the state. However, there are some exceptions that this bill will address with the benefits that are covered. HB 1145 would require coverage for adult hearing aids to users, non-profit health services plans, health maintenance organizations, commonly known as our carriers, for up to $1,400 per hearing aid every 36 months. It will also allow the insured member to purchase a more expensive hearing aid and then pay the additional costs without a penalty. This bill was actually introduced previously, not by myself, but another delegate, and it currently is cross-filed over in the Senate this year with SB 397. During the process of gathering support documentation, I received a letter from the Office of the Attorney General with some suggestions to add over-the-counter OTC hearing aids as defined by the FDA now, which is in your packet. Plus, according to the Maryland Insurance Administration, MIA, federal regulations prohibit most large plans sold in Maryland to include a dollar amount. Therefore, there will be a second amendment that's being drafted. We just don't have that as of today. They said it will come very shortly. Amendment is necessary to remove the actual $1,400 limit because of federal law. So therefore, this bill completely changes, and I'm going to explain that to you. So now, with the amendments, HB 1145, as amended, would expand the current requirement for private, individual, and group insurers in the state to provide hearing aid benefits for minor children for each hearing aid impaired ears every 36 months, and here's the key, and require the same coverage for adults. The bill also cures, which you'll see in the Attorney General's letter, cures the presumptively discriminatory benefits designed under some of these plans by continuing to keep the age limit to just minors in the non-grandfathered individual and small group markets, and offers a benefit to the adults in the grandfathered and large group markets. So this bill, really, we already have hearing aids covered in several of our plans, but there's a small percentage that does not have the availability of the adult hearing aid. So that's the small group that we're looking at, that we're trying to get covered here. There's several different written testimony in your file from carriers, and they have a lot of information in there of why this bill is so important to our elderly population. Plus, if you really think about it, the younger generation will most likely continue to have hearing impairments, and they will need that as they grow up past the age of 18. So I hope that you would take a look at this, and it would make subcommittee, and we could look at those appropriate amendments. And I request a favorable report on HB 1145. Be happy to take any questions.
Are there any questions for the delegate? Okay, you seeing none, you did a great job.
Thank you.
Thank you very much. Actually, let me ask you one quick one. I see an unfavorable from the League of Life Insurers. Have you spoken with them?
I have not spoken to them, but I do have his letter. And he had some suggestions in there, which I have been trying to actually take care of, but I guess because within the last couple days, I've reached out to, or tried to reach out to the Maryland Health Benefit Exchange.
Yes.
And I've heard you say that many times, if we put a bill in here, make sure you talk to them. So I have reached out like twice, 3 times.
Okay.
And I haven't received a phone call back, so I don't know if I have the wrong person that I'm trying to reach out to, but I'm still working on that. Would love to talk to them, because I do believe what Matt had said in the letter, and hearing what you said on many other bills. And also kind of address that, yes, we do have current coverage on several of our plans, but just not all of them. And it is a small market that we're trying to look to get covered.
Can I ask you a favor? If you will be so kind and reach out to Ben Steffen.
Ben, okay.
Yes,
wasn't him, okay.
at MHEC. Not MHEC, I had MHEC on my mind.
The commission?
Yeah, MHCC.
Yeah, the commission,
Sorry.
yes. Okay,
I just
yep.
did an email regarding MHEC, so it was on my mind.
I've
If
done
you
that.
could reach out to Ben Steffen, that would
Yes.
be great. And I can give you his information if you don't have it later
Great.
on, okay?
Thank you, Madam Chair.
And Matt just came in. I know he did not sign in, but Matt, if you could work with a delegate and try to see if you can make this work, okay? You got it. Thank you. Thank you. So this actually concludes the bill hearing on House Bill 1145, and thank you, Delegate. Next, we have House Bill 583. Delegate Cardin, is he here? Is Delegate Cardin here? He's not here. Let's go on to House Bill 811. Delegate Vogel, is he here? Delegate Lewis, 490. You're on. And the other delegates, they just have to wait until you're done. So 490, Delegate Lewis, Residential Service Agencies Employee Registry. Can you come up with your panel, please?
Yes, ma'am.
And you can get started.
Thank you, Madam Chair.
My pleasure.
Delegate Robin Lewis, on behalf of House Bill 490. My panel is coming up.
Thank you. You know, we're going to keep it moving because I want to get my members out. So go ahead.
And I do appreciate that consideration. I had to wait in another committee, which will go unnamed, for an hour when I was late the other day. So this is a little payback. I'm here, Delegate Robin Lewis, on behalf of House Bill 490. This is a bill that proposes to create a registry in the Maryland Department of Health that will capture the name and working location of home care workers, also known as personal care assistants, that are employed by residential service agencies. So this is basically designed to be a good governance bill and a healthcare workforce planning bill. I hope that you, in your wisdom, will support. As we've heard a number of times over the last several weeks, we have a healthcare workforce shortage. We also have the unfortunate distinction of having the third longest wait list on the Medicaid waiver for home and community-based services in the country. That means that over 30,000 of our constituents are waiting for home care services. And that's partly driven by the fact that we don't have enough home care workers, and of those that we do have, we don't necessarily know where they are, how they could be redeployed. The bill highlights the rising need for home care services in Maryland, and we have information that suggests that we're going to need about 40% more home care workers than we have now. It's a lot for us to do. Now, with regard to residential service agencies, for those of you who are new, these are organizations, typically small businesses, that are contracted with the Medicaid program to provide personal care for people in Maryland. Right now, we know there are 310 Medicaid-enrolled residential service agencies or organizations. They employ about 7,000 home care workers, home care aides, personal care assistants. And you'll hear a little bit more later about how some of those workers are employees and some are contractors, but we won't get into that with this bill. So we want to create a registry. We want to know who the home care workers are and where they are. I am aware that there are some concerns about the contours of this bill. The Department of Health has expressed some concerns, and a few other groups have as well. I would like to reassure the committee that I've been in close contact with the Department of Health, with AARP, and other stakeholders. So I hope that we can find mutually agreeable solution for their concerns. A few amendments have already been suggested, and we're ready to work on that. So with that, I'll leave it at that because I look forward to your questions. But as I close, I do ask for your support, and I'd like to let my panel get started.
May I please start with, let's see, Jennifer Gibson.
Chair Penna Millen and members of the House Health Government Operations Committee. My name is Jennifer Gibson and I live in Charles County. I've been a home care worker for 15 years, serving clients in Baltimore and Montgomery County. I urge the committee to issue a favorable report on HB 490, which is the first step the state must take to support thousands of families who rely on home care services in the state. Because of low pay and poor benefits, many of my colleagues leave the field for more stable, less stressful jobs, and thousands of Marylanders are relying on home health care services. But we have no plan in place to ensure we are retaining workers and ensuring they have the training they need to adequately take care of patients. If the state valued this work, we would not be struggling the way we are. Currently, I have been assigned a patient with Alzheimer's disease, and my agency has not given me the training to care for the dementia or Alzheimer's individual. I personally do not feel comfortable providing care without that training. I was informed that last year the General Assembly passed legislation to require dementia training for direct care workers, but I was not aware of this. I wonder what other information I'm missing because the state has failed to let home care workers know about training opportunities and updates. During the pandemic, CNAs were getting information from the state about being essential healthcare workers and were offered child care benefits and PPE. Home care workers are on the front lines providing care in people's homes, but we are completely neglected. I was taking care of my older father, and I was worried that I would spread the COVID-19 to him. We need legislators, policymakers, and data analysis to pay attention to the home care workforce. I respectfully urge a favorable report on HB 490.
Thank you for sharing your story. We appreciate it. May I have Vivian Boone?
Thank you, Chair, members of the Health Government Operation Committee, for the opportunity to testify today. My name is Vivian Boone. I live in Baltimore City, and I have been a home care worker for 35 years. This work is deeply personal and intimate. You get to know your clients up close, personal, and become like family. Home Care Worker Registry is a tool for the state to understand how to better support home care workers. Does the state know how many workers are living in poverty? How many struggle with accessing home care? How many have certification of a GNA or CNA? During the pandemic, many families chose to take their loved ones out of nursing homes, and the need for home care service boomed. During the pandemic, we were overworked, inappropriately paid, while other essential workers received information about the pandemic. Home care workers was largely left out. Our agencies could not be trusted to relay the information from the state. A home care registry is a tool for workforce development. More than half of residential service agencies lack educational opportunities to advance in their career. This is why we are leaving the field in addition to low pay. We are on our own trying to find training that would help us help our clients better. Let me tell you of a day in a home health care aide. We assist with baths, preparing meals, laundry, having meaningful conversations with your loved ones, shaving, hair care, foot care. I want to know how to cater to specific needs of those who have Parkinson's disease, Alzheimer's, and dementia. Without the registry, the state would be completely unable to help thousands of families struggling to keep their home care workers for their daily needs. For those reasons, I ask you to please vote yes on HB 490. Thank you.
Thank you for sharing your story. It's really moving. Thank you. You can go ahead.
Thank you, Chair Peña-Melanek and members of the House Health Government Operations Committee. My name is Lorraine Arikat. I'm the Senior Policy Analyst with 1199 SEIU. Building a strong care infrastructure starts with addressing the care gap. The projected need for home care workers is expected to increase with 74,000 openings by 2030, while we have an increasing need for home care workers in the state. HB 490 is an important state oversight tool that will address that care gap. As a member of the Commission to Study the Healthcare Workforce Crisis, I can say that the state has largely failed in gathering data on personal care aides. We are collecting demographic and training data on other healthcare support professionals like CNAs through the Board of Nursing, which has helped the Commission think about ways to improve retention and the education pipeline. But we can't do the same for personal care aides. The only data we currently have is a system that tracks when workers check into work, but this data is just simply not comprehensive. We have no way to understand retention trends, training needs, or workforce development areas of growth. In 2017, Massachusetts passed the home care registry, well before the pandemic. Because of the registry, all home care workers received letters from the state of Massachusetts saying that they are essential healthcare workers. This helped to make sure that Massachusetts workers had appropriate protective gear and guidance during the ongoing COVID-19 pandemic. But in Maryland, home care workers were largely left behind. Massachusetts was also able to collect data to find that a greater percentage of workers in healthcare support occupations reported one or more underlying medical conditions that increased their risk for spreading COVID-19. This finding, among several others, helped the state adequately support home care workers during the pandemic. But I worry that Maryland is neglecting home care workers and will not be equipped for a future pandemic. Establishing a home care registry is the first step to gathering data to adequately address Maryland's growing need for home care workers. And for those reasons, I urge a favorable report.
Great timing. Thank you. You do have someone else on your panel, David Rodwin. Yes. Is he here? Thank you. Can you come up and give your testimony?
Good afternoon, Madam Chair, Madam Vice Chair, members of the committee. My name is David Rodwin, and I lead the Public Justice Center's Workplace Justice Project. We're here in support of HB 490. You've heard from others that Maryland has a home care workforce crisis. We have a ballooning need for home care workers in Maryland. More and more Marylanders want to age in place in their homes and communities rather than in nursing homes. We saw during the pandemic the health benefits of aging in place rather than in congregate care facilities. We do not have nearly enough workers to meet that growing need, nor do we have the data necessary to make informed policy decisions to ensure that we can solve that crisis. Thanks to the Vice Chair's leadership, we have a commission to study the healthcare workforce crisis in Maryland. It's been so clear during the meetings of that commission that we do not have adequate data on this largely publicly funded workforce, mostly Medicaid. And even though it's public dollars funding the work, we don't know how many workers there are, we don't know what they're being paid, we don't know all sorts of other things about them. And it's very, very difficult to solve a problem when you don't have the data necessary to figure out what the solutions are. So this bill is about addressing that problem, getting data to policymakers so that policymakers can make informed decisions to solve this crisis, which is only going to get worse as demographics change in Maryland and as we become an older state. This is a simple, common sense way to improve data and transparency in the state, and for these reasons, we ask for a favorable report. Thank you.
Thank you for your testimony today. Are there any questions for this panel? I'm going to start with Delegate Chisholm, followed by Delegate Morgan.
I'm sorry. Thank you, Madam Chair.
Pleasure.
I guess this is probably going to be for Delegate Lewis. I'm looking on page 2 of the bill, and it says, when we're gathering this data, we're going to include in each employee's full name, identification number, job title, gender, home and mailing address, completed trainings, and employer. So I did some research yesterday on something else, and June 21st, 2021, over 1.3 million claims investigated by the Department of Labor confirmed fraudulent. December 2021, Maryland Department of Health website compromised after cyber attack. Now here's a quote from one of my favorite people, actually, who's now gone. February 7th, 2022 headline, Maryland U.S. Attorney Office continues to fight fraud. Former Delegate Eric Barron. His advice was, we encourage the public to guard your personal information. Criminals are trying to capture your information to compromise your identity and access your financial information. We found 17 fraudulent websites which appear to have been used to collect the personal information of individuals visiting the site. 3 Maryland men conspired to fraudulently obtain more than $2.7 million in unemployment. I fail to see, and maybe you can help me understand, how providing all of this very vulnerable information is going to help bring more workers when all you're doing with providing this information is making them more susceptible to fraud and possibly cyber attacks and personal loss.
Thank you, Delegate, for the question. And I'll say that your diligent and relentless attention to the protection of personal private information is commendable, and I appreciate your flagging the risks involved in collecting that data. I'll also just mention that our U.S. Attorney, Eric Barron, is a former member of this committee, so he got his training here. But in any case, with regard to collecting the data points that are enumerated in the bill, I'm aware that there is some objection to collecting those data points. I've spoken with the Miss Tricia Roddy at the Maryland Department of Health, the Medicaid director, about her concerns. And I do think that at any time when personal private information is collected, there's a risk. We share our personal private information when we open a bank account. Our information can be accessed when we use our credit cards if someone wants to hack into a system. So there are inherent risks. However, what this bill asks for is for the Department of Health to collect that data and make it available to policymakers and certain other audiences. I think that the fact that we did have a cybersecurity hack during the pandemic under the previous administration, and our Department of Health was left completely flat-footed, is a flag, right? That there are risks, but I believe it's possible for the department to collect information, to keep it safe. But I am also inclined to work with the Department of Health and revisit some of the data points. Maybe we might not need all of them. But remember the point of the bill. It's to help us as policymakers know how many healthcare, personal care aides there are in the state, where they work. We need to ask some identifying questions, perhaps not all. And I welcome your feedback if we work with the department on that. What items you think we might be able to flex? So thank you. I hope I answered your question.
My pleasure. Delegate Morgan.
Thank you, Madam Chair. Kind of with Delegate Chisholm a little bit on this bill. I'm always apprehensive when government starts creating lists and keeping track of people. I know we live in a post-age of enlightenment, but a lot of these bad things that happen in world history and in society have happened when the government started creating lists of people. I'm looking at it in the bill, and I'm just slightly a little bit confused. It says included in each employee, full name, identification number, which I think might be bad, job title, gender, home mailing address, completed training and certifications, and employer, which all seems probably pretty acceptable. But then it goes and it says, in a manner determined by the department. And then you jump down to subsection 2, and it says it may not collect data on domestic violence, rape, sexual assault, or stalking. So it kind of leads me to think that the department can collect more information than what is explicitly assigned in the bill under those 7 subsections. And I'm just wondering if you're going to collect, if the department's going to collect more information than what's in the 7 titles there, what are other information would the department be interested in? Like vaccine status, financial information, political affiliations? I mean, I guess the question could be endless there. But is that true? Does the department have the power to collect additional information?
Thank you for the question, Delegate, and I also appreciate your conscientiousness. First things first, some amendments have been proposed and accepted. This bill is cross-filed in the Senate, and some of the concerns were addressed in the Senate process, and I'll just let you know. I should have let you know sooner, knowing that you are so conscientious in that. Okay. So regarding the provision about collecting data about domestic violence, and that's proposed to be struck. So I have an amendment before me where that will be removed, and the coalition of advocates felt that was important as well. But look, the state of Maryland, the government, it's actually you and me, and we already collect information about political affiliation. If you register to vote, the state knows your party affiliation. But I think your question gets more to who's collecting the data and how they'll use it. And I appreciate that. The data that we propose to collect, and that long list, we may not need all of it, but the data we propose to collect will be used for understanding and making projections and planning about this category of healthcare worker. I think the most important aim of the bill is to achieve that goal, to know how many workers we have, where they are, how many we need, and what the heck we, the government, are doing to build that pipeline and make it easier to retain those workers. So I hope I answered your question.
You mentioned some amendments. I do not see them in the file. Am I missing them?
Yes, ma'am, and if so, I take responsibility for that and we'll get them to you.
Will you make sure that council gets it and Michelle as well, okay?
Will do.
Thank you. Delegate Hutchinson.
Thank you, Madam Chair.
My pleasure.
Delegate Lewis, maybe I'm just naive as a freshman delegate, but why are we giving the department the right to release the data to a labor union or employee organization?
That's a great question. That is a provision in the bill. I think since we're only allowed to have one person answer one question, if it's all right, Madam Chair, I'd like to turn the answer to Ms. Ericott.
Sure.
Thank you for your question. I think just to iterate, the home care registry bill is going to be collected by the Department of Health, and it will be public to all stakeholders that are interested in understanding how to support home care workers. So this could be data analysis, policymakers, and the interest of labor unions is to protect home care workers and any workers. And so we just want to make sure that the registry is public to all stakeholders that are interested in that information.
My pleasure. Are there any other questions? Delegate Shalega.
Thank you, Madam Chair. I wasn't going to ask until that you answered that question. So could a commercial entity, let's say Aflac, get that list? Because they would want to contact, under your rationale and the way you said it's worded, they could support those employees.
That's a great question. Thank you, Delegate. I think you're right. I think the logical ending of that provision is that potentially other types of organizations could request that data. But I also believe that it's in our power as the state to build any reasonable and necessary regulations around that. But I'd be happy to think about that and work on that more. Again, this bill is important. I think we need to do something to get a hold of the home care workforce. But I am open to discussion and looking at ways to make the bill better. So that might be one approach.
If someone opt out, I don't see an opt out either. Would you ask their permission before you shared their information?
Oh, for the workforce, the workers? Yes, ma'am, absolutely.
It's not in the bill, but you're building in an opt-in provision, not an opt-out.
It's already under regulations, but I appreciate you flagging that. Thank you.
Thank you. Seeing no other question, thank you very much, Delegate, for your testimony today and for your panel. Next, we have favorable with amendments, Michelle Siri. We have Tammy Bresnahan from ARP, and we have, we'll bring you two up if you'll be so kind and testify.
Good afternoon, Madam Chair, Madam Vice Chair, members of the committee. My name is Michelle Siri. I'm the Executive Director of the Women's Law Center of Maryland. I will be very brief. The Women's Law Center is in full support of this bill. The care workers are, as this committee I'm sure is aware, disproportionately women and women of color in particular. And then the folks who are in the wake of the shortage of caregivers giving the care at home are also disproportionately women. So we're in full support of anything that's going to help address this crisis of care. I was really only here to ensure and to thank Delegate Lewis, yes, Delegate Lewis, sorry, for the amendment that removes the victims of domestic violence, intimate partner violence, and sexual assault. We appreciate that the intent was there to help include privacy, but we thought it actually was better taken out of the bill, and so we appreciate that amendment, and otherwise are here just to answer any questions. Thank you.
Next, please.
Good afternoon. I'm Tammy Bresnahan, Madam Chair. I'm glad to be here again in less than 12 hours, so it was a very exciting day yesterday. We are in support of House Bill 490. We are supporting Ms. Siri's amendments and any other thing that makes it private or not private, but actually secures information. ARP believes that the state should establish and maintain a home care registry, especially when state dollars are there. How are those state dollars being allocated? Who are they paying for? What's the training that they have in order to get those state dollars? So it's an audit, and it's making sure that the state is paying for what it's saying it's paying for. So with that, we ask you for a favorable report with amendments on House Bill 490.
Are there any questions for these two witnesses? Seeing none, thank you so much for being with us, and if you can continue to work with all involved. Next, we have Ms. Kaufman. And you are all on your own.
I am. That's okay.
You're enough, right?
And for the record, I'm Dana Kaufman. I'm here on behalf of the Maryland National Capital Home Care Association and Lifespan Network, and we are opposed to this bill. And I just want to be very frank and very clear of what this bill is actually saying. And it's basically requiring 4 times a year for residential service agencies to report personnel information to the health department. And that's all it is saying. It does not have any purpose of how that information will be used. And then in that last section, which has been noted, it says that that list can be then disclosed to or will be disclosed to a labor union or any other employee association. And as has been pointed out, it also means that that list can be available publicly for any company for solicitation purposes. It has no opt-out. It has no opt-in. To address a couple of the points, first of all, this bill only applies to employees. If there is a concern about knowing where our home care workers are, that is already available to the health department. The in-home support assurance system, which applies to all caregivers, regardless of designation, 1099 or W-2, each residential service agency has to have a caregiver profile on file with the health department, which includes information on the caregiver as far as some of the same information that's in this bill, as well as the number of hours that they are working. That is how they get paid. If they don't have that information in there, they will not get paid. So if there is a public purpose of having more information, it is already readily available. We do not think that this is a good use of resources. I would also have you look at my written testimony. There is a provision in law, Section 4-501 of the General Provisions article, that we think is in conflict with this bill. I'd be more than happy to go into more detail if you like. But with that, we would ask for opposition. Thank you.
Any questions? Vice Chair Kelly, followed by Delegate Hutchinson.
It just sounded to me, Dana, like you wanted to finish your sentence about the conflict, so I would like to ask you about that.
Thank you very much.
And for the record, you stopped yourself. Because I did not say anything, but go ahead.
I'm very aware of the bill. So there is a provision I would ask everybody to take a look at. It's Section 4-401, and it deals with state agencies collecting information and how that information has to be collected if it's personal information, which would include names and mailing addresses and other information that is contained here. And if that unit does not have a clear and established public purpose, first of all, it can't be collected, but it also has to be collected by the person in interest, which here would be the caregiver, not by the residential service agency. So I think that is a section that needs to be noted, that there could be a conflict if you were to pass this law with what is able to be collected in that manner. Thank you.
Delegate Hutchinson. All right, you have to love it when it works out. Delegate Kaiser.
Thank you, Madam Chair. Excuse me. As I listened to your concerns, and they seem like good concerns, but I guess I'm wondering, did you see value in the ultimate purpose of what Delegate Lewis was trying to do? And if your specific concerns were addressed, do you then see that it would still be, would you then be support with amendment? I'm just trying to understand if you appreciate the goal that she's going for here.
I do appreciate the goal, and I think that that goal has been shared throughout this session and last session. Without a doubt, we have a workforce shortage crisis, which is why we have the commission. And the commission that's looking at it is looking at home care workers as well. So I think that there is already a mechanism to try to address that situation. We don't see how this bill will ultimately address that situation. It is simply a database, and without knowing where that data is going, it raises a lot of red flags to us.
Okay, I don't see any other questions. Oh, you do? You're light. Okay, go ahead.
Oh, thank you, Madam Chair. Diana, would you agree that this registry would provide information about the employees, including their training and certification, which could be very important for determining their qualification for providing care? And the registry could help identify any employees who have a history of abuse or neglect, which could help protect patients from harm. Do you agree on that?
No, because, respectfully, trainings and certifications are actually mandated under the law. And again, though, and this is going to be a bill for later, there is a difference between the 1099s and the W-2s. So the trainings and certifications that are required under the law only apply to employees, not for the 1099s. They may have a choice for doing that, but what I had said before, as far as the system that Medicaid already has this information as well. So we do think it is in some place duplicative. And we also think that monies, given limited resources, would be better spent on allowing the department additional staff to approve care plans, which right now are being so delayed that individuals can't even qualify for services. So we think that there is just different ways to go about addressing workforce shortages and things along those lines than this bill.
Any other questions? Seeing none, thank you. We have two virtual testimony, one from Christopher Meyer and Geneva Stone. Will you get started? Ms. Stone, will you be so kind and get started?
Yes. Dear Chair Pena-Melnick, Vice Chair Kelly, and members of the HGO Committee, my name is Geneva Stone. I'm an author, advocate, and mother. I'm also a member of the task force to study the healthcare workforce crisis. I serve on the Workforce Data Group. My son, Rob Stone, artist and advocate, has disabilities and complex medical needs. He lives at home with the support of Medicaid waivers. Living in his community is his civil right. As a healthcare consumer and advocate, a home care registry appeals to me. The staffing crisis is threatening my son's ability to stay home where he belongs. And I don't know what to do or how to plan because the state isn't doing anything to resolve this. You know, families like mine are just left in the dark about this, and we're distraught. So my dad worked for IBM, and from him, I learned that lists and data are the cornerstone to getting anything done. From my service on the workforce data subgroup, I know for a fact that there's just no good data on home care at all. And my personal experience over the last 2 decades of my son's life has led me to believe that home care has always been an afterthought in Maryland. And it's really time that changed. With a home care registry, the state would have data reports on workforce development, training needs, retention rates, and our ability to support our growing need for home care services. I want Rob to live the life he wants. And he can't do that unless we can solve this crisis. So this is the first step in gathering transparent data about our home care workforce. I urge committee members to issue a favorable report on HB 490 to invest in and strengthen our care infrastructure with state oversight and data. I support sponsor amendments. It's time Maryland got serious about home care. Thank you very much.
Thank you for your testimony. Next, please.
Thank you, Chair Pena-Melnick, Vice Chair Kelly, and members of the committee. My name is Christopher Meyer. I'm a research analyst at the Maryland Center on Economic Policy. We support House Bill 490 with sponsor amendments because it would systematize the state's data on the home care workforce and help to strengthen that workforce in the long term. Home care workers are, home care workers are a vital part of the social infrastructure that keeps Maryland going. But today, as this committee has heard, we face a severe and growing labor shortage in the industry. Without effective policy solutions, population aging is about to make this shortage worse rapidly. Maryland's 65 and over population grew by 18% from 2015 to 2021. It's projected to grow by another 29% by 2030. Meanwhile, our working age population is essentially flat. At this rate, we will be increasingly unable to meet the need for home care as time goes on. Policymakers cannot effectively address this crisis without high-quality information. Unfortunately, the state's current data systems just aren't up to the task. Without specific requirements, our constellation of private home care agencies produces only limited and fragmented data. House Bill 490 would improve the knowledge base policymakers can draw from to make effective decisions, strengthen our home care workforce, and meet aging Marylanders' needs. For these reasons, I respectfully ask for a favorable report, including the sponsor amendments. Thank you.
Thank you for your testimony. Are there any questions for these two witnesses? Seeing none, thank you for your time and thank you for sharing your story. Thank you. Have a wonderful day. This actually concludes the bill hearing on House Bill 490. Now we're going to go to House Bill 583. Delegate Cardin, will you be so kind and bring your panel if you have one? Health insurance reimbursement, what happened? Oh, sorry, reimbursement for infusion of medication. Good afternoon.
Good afternoon, Madam Chair, members of the committee. It's a pleasure to be here and see you and see the civility of a committee. It's a little different than what we see in judiciary, so it's always nice to be here.
Thank you.
This bill, just very briefly, came to me from a constituent who is a podiatrist, and that he explained to me a situation where certain insurance companies, not all, but some, will, when you, every quarter, the insurance companies come out with the new rates come out, and the insurance companies have to comply with those new rates. You guys know this stuff much better than I do, so if I'm dumbing it down, you can probably ask the experts, not me. But when they get the new rates, they have to comply with them and reimburse in the amounts that the I don't know what the organization is that comes up with the rates. And almost, it happens quarterly, and as soon as the rates change, the reimbursements to these providers change immediately, except some insurance companies float an extra month or two before they provide the increased reimbursement. And so what's happening is the providers are getting the lower amount for a month or two, and the insurance companies, even though they're required to reimburse at a higher rate, are gaining the ability to float additional savings for those few months. So I put in this bill that basically requires the reimbursements to adhere to the quarterly schedule that the reimbursements come in from the agency that provides those numbers. I have been told, I've looked into it a little bit, and I've been told by one person who I believe might be testifying, my good friend, Deb Rifkin, I don't know if she's going to be testifying or not, or she may have just provided written testimony, I'm not sure.
She's actually testifying.
Okay, so that this is a federal issue, and that the state can't impact it. So if that's in fact the case, then this bill wouldn't do any good. So, but if we can impact it and we can help providers get the correct amount, why shouldn't we make sure that that happens? There's no reason why some insurance companies do the right thing and other ones do the wrong. I've also been told that this is a system that is done by hand with handwritten spreadsheets, and it's not computerized, and therefore it's impossible for them to get it all done in a timely way, to get it done at the quarterly time, because they only have a certain amount of time to get the reimbursements done. So they need that extra month or two to be able to provide the proper reimbursements. I did provide an amendment to council that actually opens it up not just to the podiatry providers, but to all healthcare providers, because they're not the only ones that provide this type of infusion medication. But again, this is really geared towards those folks who came to me and said, we're being harmed because we're providing the service, we're supposed to be reimbursed by a certain amount. It's in law, it says it, and they're giving us the lesser amount because they say they can't get it done in a certain time period. And that's the reason for the bill.
Thank you. We do have questions. The first one is from Delegate Hill.
Thank you, Delegate Carton. I don't really know how this works, but it would seem to me, and I'm asking if you're okay with this, that folks should be required to reimburse at the rate that had been set on the day the treatment was given. So whether it's set by the feds or whoever sets it, I don't care about the quarter. If I gave it on January 5th, what was the rate on January 5th? That's the rate you should be reimbursed at. And if you gave it on January 12th and it's a different rate, you should be reimbursed at the January 12th date.
And I thank you very much for that really articulate question, because if you can figure out a way to get that into language into the health article, that would be spectacular. I'd love it. I focus on the criminal article and the civil procedure article. So,
Any other questions? All right. Seeing none, thank you for being with us.
thank you very much, Madam Chair.
My pleasure. Thank you for being patient and waiting. We do have two unfavorable. We have Matt Chantilano and Deborah Ripken. And for the people in the audience, there are seats to the right. A lot of seats are available on the other side, a lot of chairs. If you go through the other door. Thank you. You can get started.
Thank you, Madam Chair. Members of the committee, I'm Debbie Rivkin, Vice President Government Affairs for Care First Blue Cross Blue Shield, in opposition to this bill. And I appreciate Delegate Cardin understanding our point of view, and so I just want to share that with you. It's not that we don't want to pay as quickly as possible. It's that in this particular instance, we really are at the mercy of CMS. So what happens is, for these particular drugs, on a quarterly basis, CMS puts on their website, so we actually have a person that has a tickler every quarter to start looking on, a month out, go to cms.gov and look for an actual Excel spreadsheet. And when that finally comes up, then we have to manually look at every single line and figure out which of those drugs on the sheet match our different formularies. And then so we have to, by hand, pull them out and put them into our spreadsheets, and then figure out, based on our contracts, our rates, what the new rates will be. There have been times, in particular last quarter, where the rates weren't even posted on CMS's website until 1 week prior to the quarter starting. So at that point, our person had to sit there and pull out, and it's over 1,000 lines, 1,000 drugs, and they had to figure out which ones we had on our formularies. As soon as we finish it, we update and we shoot it out. But it cannot be done on the quarter until CMS starts sending it to us in an electronic format that we can quickly change things. But because of how manual and intensive it is, we need a lag. So because we don't think that this is really workable until we can figure out a better process with CMS, we would ask for an unfavorable report. Thank you.
Thank you.
Madam Chair, Matt Celentano here today on behalf of the League of Life and Health Insurers of Maryland, also in opposition to House Bill 583. Ms. Rifkin said most of what I was going to say, so I'll keep it brief. We're opposed because the bill is impractical. Carriers are beholden to CMS, and the process is, as Deb said, clunky. It's labor intensive, and the reimbursement rates come to us in an analog way. The process of uploading the data is not automated, like you heard, and there's a lag in processing each one of those reimbursements. It can be over 1,000 drugs. I just wanted to make sure it was clear. It's a lot. It's not just a couple of drugs. Carriers are also required by law to process and pay any claim submitted by a provider in 30 days. That is still happening. That's not going to change in this bill. And then one last thing is I did contact Associate Commissioner Cooney with the MIA this morning to ask if there were complaints from providers on these proprietary drugs, and he said they have not received a single complaint. So we will continue to work with providers as usual, but I've heard from Deb and myself that it is a clunky process, it is not automated, and we are at the mercy of CMS. So we ask for an unfavorable report on House Bill 583.
Thank you. Are there any questions from the committee? Delegate Hill.
Thank you, Madam Chair. Matt, Deb asked me to come and talk the next question to you after the last hearing. She said, ask Matt the next time you have questions. So I'm going to direct it at you. This bill that Delegate Cardin's introduced isn't about lag time. They're not suggesting that there's a lag time. They're saying that the reimbursement rate doesn't match the reimbursement rate that's supposed to be given. So even if it takes additional time because CMS doesn't give it, what I'm not understanding is CMS has an effective date. This price is effective even if you don't find out about it till 12 months later. There was an effective date when that price went in. Why can't they be reimbursed at the correct effective date? What was the price on the date the service was provided?
I don't know an exact answer on that for you, Delegate Hill. I do know that the prices do fluctuate, and they do go up. Sometimes they go down. I would imagine it would be what the price was when the claim is filed, but I'd have to double check.
1 second, please. 1 minute before you leave. Edith, can you please introduce the group that's here today? And welcome. Thank you for visiting us today, and thank you for all the work you do. We really appreciate it.
We're here to support the bills and work.
Thank you. Delegate Hill, you may continue. One more. Thank you.
The insurers often do a thing where if they think they've overpaid, they come back and tell the provider, we're going to take money back out of the next patient, so we'll ask for a return. So if it turns out that they've underpaid, why can't they say, here's an additional check, because we found out that when we reimbursed you, the price was actually more?
And I think my answer is before, I'm not sure if that happens either way. I'd have to check for you, Dr.
Delegate Johnson, no more? And I don't know if the question was asked because I was trying to multitask, but the fiscal note says that some medications, including those administered, this is page 2, via infusion by a licensed podiatrist, increase in cost on a quarterly basis. Commercial insurers may not routinely adjust their reimbursement rates to reflect these increases. Did you address that?
So what we do reflect it, but not on the exact quarter. So it's not done on January 1, April 1, because that's what we need a lag time, but we absolutely adjust based on CMS prices.
All right, thank you. Delegate Johnson.
Thank you, Madam Chair. You said, Matt, that you don't know the answer to that. Can you get the answer to that if they are getting paid the difference? If you guys don't know and they're getting paid an outdated amount, if they're going back and paying them the difference, can you get that information?
Yeah, my assumption is that would not be the case, but I don't want to give you an answer if I'm not 100% sure, so I'll get the answer for you.
Thank you.
Yeah.
Thank you, Madam Chair.
And when you send the information, will you be so kind, Matt, and send it to our attorney?
Yep, absolutely.
And also the committee. And thank you very much for being here today.
Thank you all.
Our pleasure. This actually concludes the bill hearing on House Bill 583. Thank you, Delegate Cardin. Have a great day. And the next one is House Bill 811. Delegate Vogel, hospital overdoses, testing for fentanyl. If you have a panel, please come over with your panel. And as soon as you sit, will you be so kind and get started, please? You can get started. Yes.
Madam Chair, Madam Vice Chair, members of the Health and Government Operations Committee, thank you for allowing me to testify before your committee in support of HB 811. First, I would like to acknowledge the individuals joining me on this panel today. I believe we also have one person testifying virtual on this panel. Carol and Bob's son Josh passed away late last year from a fentanyl overdose. Josh's partner Melanie, sitting to my left, they have turned their grief into action and are hoping their loss leads to legislative change. Their courage is on display today, as is their love for their kind, passionate, and loving young son and partner, who I have had the privilege of learning more about in these last few weeks. Thank you for sharing your story and for your determination to combating the fentanyl epidemic so no more families need to feel this heartbreak. Joining us on Zoom today from California is Julie Shamash. Julie lost her son Tyler when he was just 19 years old, when he overdosed at a sober living facility. Tyler took drugs that contained fentanyl, but he was never screened for fentanyl in the emergency room. Recognizing that had it been common practice to screen for fentanyl in emergency rooms, Tyler might still be alive today. Julie led an effort in California to pass Tyler's Law, legislation requiring hospitals to test for fentanyl when conducting a standard urine drug screening. Tyler's Law passed unanimously in California's legislature and was signed into law by the governor. Stories like Carol's, Bob's, Melanie's, and Julie's are far too common in Maryland and across the country. Maryland is now recording over 2,000 drug overdose deaths a year. According to the most recent data, 81.5% of all fatal overdoses are fentanyl related. These numbers are staggering, but they're not reflective of the full scope of this crisis. A new report by the University of Maryland's Center for Substance Abuse Research finds that most emergency departments are screening only 5% of overdose patients for fentanyl. And when fentanyl tests were conducted, positivity rates exceed 40%, more than 3 times the positivity rate of opiates like morphine, heroin, and codeine. This legislation is common sense. If hospitals are conducting a urine drug screening on a patient who has overdosed, The hospital should test for fentanyl in addition to the federal 5, marijuana, cocaine, amphetamines, opioids, and PCP. This is critical considering the prevalence of fentanyl in our communities right now. This legislation exempts hospitals without chemical analyzer equipment to conduct urine drug screenings, and it does not make any changes to the Good Samaritan law, which grants immunity to an individual who is in need of medical assistance after ingesting drugs. This bill does not mandate when doctors are required to conduct tests, and as such is not legislating clinical practices. In your floor system, you will find a letter of support from Special Secretary of Opioid Response Emily Keller, who said requiring hospitals to test for the presence of fentanyl in all suspected overdose cases will improve the state's overdose data, as data on non-fatal overdose cases can be particularly difficult to collect. Today, Governor Wes Moore expressed his support of this bill, with his spokesperson saying, "This presents an opportunity for Maryland to adapt to the current realities of the opioid crisis by requiring hospitals that are able to report fentanyl in their toxicology reports. We can collect much-needed data that will greatly help in the fight to reduce the leading cause of overdose deaths in Maryland." I want to thank the governor for his support of this bill. There are 2 sponsor amendments to this bill, which have been shared with your council. These amendments seek to clarify the testing requirement, the exception for hospitals without chemical analyzers, and the section of this bill that sustains criminal immunity. I thank the committee for your time and thank this panel for your passionate advocacy. It is an honor to work with you on this effort.
Thank you. Thank you, Madam Chair and Madam Vice Chair and committee, for hearing us out today. I'm here in support of HB Bill 811. My name is Carol Symes. I'm the mother of the late Josh Symes, his brother Billy, and his sister Lainey. And in the words of Mr. Rogers and his mother, look for the helpers. That's why we're here. We're looking for helpers because we need help. We're no strangers to the medical world and hospital systems. We had 2 diseases in our family. My daughter Lainey suffers from cystic fibrosis, and we have Josh, who was an addict. It was the CF that brought us into the medical world early in my daughter's life. It was Josh's addiction and substance use disorder that brought us into the medical world a lot in recent years. And we have learned through the CF world that data collection is crucial. It has allowed that world to make great strides in the longevity of people with CF. It funds, the data allows people to fund bench science treatments and to improve outcomes. These diseases are not communicable diseases, but they affect a lot of people. It's a small but important step, this bill. It will help us approach the epidemic of opioid use disorder. When we use words like epidemic to describe a disease, we acknowledge the damage in our community is real. It compels us to take steps to positively affect the reduction of its impact. We acknowledge the deadly outcomes and that they reach far and wide and know no boundaries. While anecdotal evidence and lives lost are real,
It's okay, you could take your time.
okay, our medical and economic system, data is king. It drives investment, both public and private. It allows grants and for intervention programs, bench science, and drug development. We know that overdoses that involve heroin have gone down, and those involving fentanyl have gone up. We have numbers. Those numbers are wrong. We know that because we know that the data collection is sporadic at best and not done in many, many cases. We have a public health crisis. We need to do better. If you pass this bill, it will have a ripple effect. Just as the adverse effects of fentanyl ripple into our lives, I believe that the effects of positive actions have the same impact. It will undergird how we understand the prevalence of this drug. It will give credence to the efforts of those trying to fight it, and provide health services to those who need it. There are many, many pragmatic reasons to pass this legislation, but consider too that the passage of this bill also sends another message. It tells your constituents that you care about them, all of them. It is, in fact, an act of love. We urge you to support House Bill 811.
Thank you for sharing your story, and we're very sorry for your loss, okay? I know it's very difficult. Who will be next?
Good afternoon, and thank you so much for hearing us today. My name is Melanie Yates. I'm a Master of Social Work student, have worked in the addictions field for almost 10 years, and am one of the advocates behind HB 811. On October 14th of last year, my partner Josh died from an overdose. He'd struggled with addiction for 10 years after trying OxyContin in college. Unfortunately, in the early hours of the morning, the police found Josh in his apartment alone and unresponsive. At the hospital, Josh was pronounced brain dead. Several days later, his family and I got his urine drug screen back. It showed only cocaine, despite his family and I finding fentanyl in his apartment. It turns out the hospital had not tested for fentanyl. We know that in 2021, 80% of fatal overdoses in Maryland were linked to fentanyl, and that fentanyl is now found in every street drug, from cocaine to marijuana to fake pressed pills that look identical to something you'd get from a doctor. We want to put into place a common sense measure that asks healthcare providers to include fentanyl testing when they are already ordering a urine drug screen. Hospitals are the first line of defense in the opioid crisis. They provide education and resources for people who knowingly and unknowingly ingest fentanyl. Not only that, but the testing that occurs in hospitals directly informs Maryland's opioid prevention strategies. If we are not routinely testing for fentanyl, then we are vastly undercounting the number of fatal and non-fatal fentanyl-related overdoses that are happening in our state. This bill is a simple and logical step that we can take towards addressing the fentanyl crisis in Maryland, and I truly do believe it has the ability to save hundreds of lives. Thank you, and I urge you to support HB 811.
And thank you for sharing your personal story, and so sorry for your loss. Okay, who will be next?
My name is Bob Symes, and I am Josh's dad, and Carol's husband, and also the father of Josh's twin brother, Billy. Daughter with cystic fibrosis, who at 28 or 29 years old is doing incredibly well because of all the research and the statistics that have been gathered and analyzed over the years for how to approach cystic fibrosis patients. So we've seen how important it is to have the right information. I'm a lawyer by trade. I'm 70 years old. I don't do too much litigation anymore, but one thing I've always appreciated is that the more information I had, the better off my client was going to be. And this is information that we're just missing. And they're not missing it down in Mexico. Because down in Mexico, they know that it's cheaper to use synthetics to make fentanyl than it is to use the cocoa plant to make cocaine or to use the poppy plant to make heroin. So this is just going to get worse. So we're here asking for your help. And we believe that the right thing to do is to pass this legislation, and we ask that you consider doing just that. Thank you.
Again, thank you for your testimony, and so sorry for the loss of your son. This is the part of the hearing where the committee gets to ask questions, right, about the bill. It's not personal, it's just, we just want to know a little more to see whether we'll pass it, whether we can do it, fix it. So just bear with us, okay? So I will go on and ask one question. Oh, I know you have, you have two more. You
Madam
want
Chair,
them to
just the one
testify?
person on the screen right now, that's okay.
Absolutely. Go ahead and unmute yourself. And I forgot you were there, but I am all ears now. Go ahead.
My name is Julie Shamish. In California, SB 864 Tyler's Law is named for my son. On October 21st, 2018, my kind and brilliant son died in the bathroom of a sober living from ingesting fentanyl. The night before he died, he was taken by ambulance to an emergency room for a suspected overdose. He claimed to have taken too much Imodium for an upset stomach. I'm not naive, and I was well aware of the fact that drug users don't always tell the truth. I asked the treating doctor 3 times if they tested him for everything, including fentanyl, and 3 times he assured me their tox screen would pick up fentanyl since it tests for opioids. After Tyler died, we found out that the doctor was misinformed and the standard tox screen does not test for fentanyl as it is a synthetic opioid. Had we known Tyler had fentanyl in his system, we would have sent him to a detox or residential treatment, which offer a higher level of care instead of back to the sober living where he died. Tyler's story is just one example of a doctor not knowing that a separate fentanyl test is needed. Not long ago, I was talking to a friend who is an OB and has to order tox screens on pregnant mothers that he suspects of using drugs. He, just like the ER doctor who treated Tyler, had no idea that the standard 5-panel tox screen does not test for fentanyl and a separate test would have to be ordered. HB 811 would make it mandatory that doctors who order the standard 5-panel test would have to also order a fentanyl screen. This bill will save lives in situations like Tyler's, as well as in cases where people are brought into an ER for an overdose of one substance, but they unknowingly consumed fentanyl from a poisoned product. Sorry about that. Fentanyl is a bipartisan issue that affects everyone. I hope you support HB 11. Thank you.
Thank you for being with us and so sorry about your loss, okay?
Thank you.
So I'm going to ask the first question. Usually I don't. But I read the bill and I see that you are screening the urine for fentanyl. But there's no reporting or collection of the data in the bill. So what do you do with the information if you're not reporting or collecting it?
So I'll take the first stab at that one, if that's okay, Madam Chair. We've been working closely with Secretary Keller on this bill, and I had a conversation with her about this just the other day. She couldn't make it today, unfortunately, but I will have her reach out to your office to provide more information on how they currently process reports. They use a system called Essence, which I'm still learning a bit about, but they do have current practices in place for reporting non-fatal overdoses in hospitals. This bill does not address that directly because we know that there's already existing programs in place or programs that can be expanded through the Opioid Operational Command Center.
If you will be so kind and provide that information to the committee, right? Because you can screen, but you have to do something with that data, right?
Yep.
Data guides you to make these policy decisions or to make improvements to prevent these deaths. So thank you for the work.
Of course.
We're going to have some questions now. I'm going to start with Delegate Kaiser.
Thank you, Madam Chair. Delegate Vogel, my question was just pretty simple from something you said at the beginning of your testimony, that your legislation, if passed, wouldn't cause a test to happen. You're saying that only if there's a suspicion of drug overdose and they're testing for the 5 other drugs, that this would have to be added, and that's the only change that your bill would make?
Correct.
Okay, thank you.
I am going to go ahead with Delegate Chisholm, followed by Delegate Collison. Actually,
Thank you, Madam Chair.
yeah, go ahead. So for the committee, if you're wondering, there's 2 people there. This is the panel. They're not on his panel. We're going to ask them question after they're done, and we'll go to the other 2 witnesses. Go ahead.
Thank you, Madam Chair, and thank you for your testimony. My heart goes out to you. I'm sorry for your loss. Thank you for your advocacy and coming forward. I know it's tough. I guess my question's for Delegate Vogel. You had said that the Maryland Hospital Association their hospitals would be exempt if they don't have the current chemical analyzers. And I just did a search, and it doesn't look like it's a very expensive piece of machinery. I mean, to you and I, it's probably expensive. To the hospital association, we're talking about $18,000, $20,000. In your conversations with them, do they have any thought on adding these? And if you happen to know, do you know how many hospitals currently have it out of the 60 that they represent? And do they have plans to start to incorporate this into every one of their hospitals? Because this, obviously, this epidemic is not in any one place, it's everywhere.
Absolutely. Thank you, Delegate, for that question. So first of all, to answer the question of how many hospitals, the letter of information from the Maryland Hospital Association informs us that over 50% of their hospitals are already have this as their standard practice. That to me shows us that we are moving in the right direction and that this is something that hospitals can adopt. But 50% when we're dealing with an epidemic of this scope is just not enough, right? So this bill would provide greater urgency for hospitals to, start conducting toxicology tests in this manner, which would also include fentanyl screenings. In terms of the exception for hospitals that don't have chemical analyzers, my understanding and based on conversations that I've had with medical professionals, nearly all hospitals should have a chemical analyzer. That's how they conduct their standard urine drug screenings. And because of how this bill is worded, going back to Delegate Kaiser's question, for a hospital to be required to conduct that fentanyl screening, they already have to be conducting the standard urine drug screening, so they have to have the chemical analyzer.
Thank you. And just to follow up on that, I did see that in the letter, and I know that they basically do not want us to legislative. Mm-hmm. So I wonder if they would, and I know they're listening if they're not here, because I believe they only signed up written, if I'm not mistaken. So they're not here, but I know they're listening. So I would want to encourage them, if they can give me a letter to say that the other hospitals will do it, right? 50% are doing it, then we don't need to legislate. Sometimes you don't need a bill, right? They can do it on their own. So I know that they're listening right now, and if you could also touch base with them when this is done, okay? I do have a list. I have Delegate Collison, followed by Woods, followed by Taveras, followed by Morgan.
Thank you, Madam Chair. And welcome to HGO, Delegate Vogel. And thank you to your panel for your compelling testimony. So I just want to put a fine point on one thing that Delegate Kaiser said, and then I do want to follow up on something that the chair asked. One is only one sample would be required and to do all of the tests, including the screening for fentanyl. So that's that question. And then would you be open to discussing some sort of reporting mechanism so that we could determine how best to use, or we could actually use this information that would be gathered?
I'll defer to you in a sec. Yes, Delegate. To answer that second question, the intent for this bill is to make sure that we're collecting as much data as possible, and localized data as well. That's really helpful, specifically to the Opioid Operational Command Center. And I know the governor and Secretary Keller have spoken publicly about how they want data-driven solutions to this epidemic of fentanyl overdoses, and this is an effort to help them get that data. I'd love to have a conversation with you and Secretary Keller to figure out what protocols we can put in place to make sure that we're collecting that data in the best way possible.
I will allow it.
Mm-hmm. Question, but just I believe that we probably, because of the resources that we already have in place, like with the opioid commissions, we might be able to do this without legislation. But I think it's important for us to be clear about what we want the information for. So thank you very much.
I would also like to just chime in on what Delegate Vogel said. So all of this data is already being reported to the Maryland Health Department. That's how we're getting the current overdose, fatal and non-fatal overdoses. So when we're looking at how are we going to be able to collect this data, it's already being collected. This will just add to everything that we already have in place. And also just to your first question, it can all be collected in one. Thank you.
Delegate Woods, followed by Delegate Taveras, followed by Delegate Morgan.
Thank you, Madam Chair. To Delegate Vogel, thank you so much for this legislation. To all of you who have experienced loss, please accept my condolences. Delegate Chisholm pretty much asked the question I have, but I want to ask this. Given the chronicity of fentanyl, given the increased and diverse ways that we are finding fentanyl in products, given the fact that fentanyl is impacting from children to adults at record levels, what are the barriers for these hospitals who are not, do not have the testing equipment and are given this exemption?
Well, thank you, Delegate, for that question. And I echo your statement on the timeliness of this bill, right? That we see in my home county, in Montgomery County, just how many cases of overdoses there have been in the last few weeks in high schools, right? So this really is an issue that's affecting us all across the state, right? Some parts of the state more than others, but like one of our panelists said earlier, this is a bipartisan issue, right? It's impacting people all across the state with delegates from both parties, right? So I'm grateful that, just to touch on that point, it's a bipartisan co-sponsored bill, right? But to go back to your question, this is the standard 5, the federal 5 drugs that are normally screened for that I mentioned earlier. Those that is based on what for a long time, right, were the 5 drugs that were the principal causes of overdoses. That has changed. That's why the governor said that we have to evolve to the current situation that we're in right now. And the reality is that when you look at the data, and 81.5% of drug overdoses or fatal drug overdoses are caused by fentanyl. We have to realize that those 5, it's just not enough. So this should be the new legal standard, right, that we're testing for fentanyl in addition to the standard federal 5.
And at least regarding barriers, after I've spoken to Julie Shamish and Dr. Ronit Lev, who are the 2 advocates for the California bill, they found that they received 2 phone calls from the entire state of California on an IT issue on how to select fentanyl into the lab set. That's it. That has been the only barrier to implementation there.
So Delegate, we only allow one person to answer. So as we proceed, it's okay, because I know it's emotional. So as we proceed, please decide who's going to be the best person, okay?
Will do.
We have Delegate Taveras, followed by Delegate Morgan.
Thank you, Madam Chair. Good afternoon, and I'm sorry for your losses. This is a very sensitive issue. But going back to the numbers, as I read the letter from the Maryland Hospital Association, they all recognize that they're only testing, out of these 50% of the hospitals, only those overdoses, they're only testing 5%. And out of those, they're finding of those overdoses, 81% are fentanyl positive. And so my question is, how realistic is this number of 2,342 overdoses in 2020 attributed to fentanyl? It seems to me that this is just the tip of the iceberg out of the 5% that were in fact tested.
Well, that's exactly the point that we're trying to make here, right? And just to clarify those numbers, it's 5 based on the UMD report, 5% of suspected drug overdose patients are tested, and approximately 41% or so of those tests come back positive. So I can't theorize on what the actual number is here, but there's a real chance that it's very significant, or far higher than what we're reporting right here. So the point of this bill is not only to get a better sense of what the number is overall, but for us to be able to understand better what communities are seeing spikes, right? And that's why the reporting is so important. What we've heard from ER physicians who we've spoken to about this bill is that as soon as they see one fentanyl overdose case in their hospital, they know that there's dozens more following that day or the next day. And that's why this information is so important, not only from a data standpoint, but also, you know, when you look at anecdotal cases like Tyler's, the person who ended up leading to this bill passing in California, consider someone that goes to a hospital, right, doesn't get tested for fentanyl. And this is what one of the ER physicians told us as well, that there are patients that come in and say, you know, I'm kind of surprised that I overdosed because I've been using cocaine for the last few years. They might not know that that cocaine that they're using right now is laced with fentanyl. They could go back home that same day, use that same drug, not knowing that they had fentanyl in their body because it was laced into that drug. They could use that same drug and end up dying the next day, which is what happened to Tyler. So the data on a systemic level is necessary, but also to empower patients with that information could save lives.
Very fast, just a question, please.
Yeah, but it's not just the issue of how many cases. It's also the issue of the demographics, because who we're targeting. Because the cases we're also seeing are as young as 13. So it's also where they're targeting. And so if we're just testing, why are we not capturing demographic information of the client who's been affected, of the patient?
Again, I'm happy to have a longer conversation, Delegate, about the reporting practices and involve Secretary Keller, because she'll be able to speak far better to the current practices and capturing that demographic data. That's slightly outside of the scope of this bill. So I don't want to, I don't want to get ahead of myself here, but that's definitely a conversation worth having.
Delegate Riley.
Thank you, Madam Chair. Yes, so with, I do say that you have the Good Samaritan law in here. I've done several bills on overdose myself. So with that particular, in there, the Good Samaritan, there's probably very limited data that you're going to actually be able to use to be able to target to where, there's no law enforcement involved in trying to target to see where the fentanyl came from. So you do know that, right? So we just have the data here. So my question was about the life-saving situation to it and getting the data and, trying to figure out, maybe areas and different things. But when they're in the hospital and they're doing the test, is there a different treatment that the emergency room is doing if they're laced with fentanyl, or if it's just a different kind of opioid that could have been the life-saving situation? Is that so, or I don't know?
Who's the best person to answer?
So thank you, Delegate, for that question. And your point is taken on the fact that this does not change any practices around notifying law enforcement. It preserves that criminal immunity that's granted under the Good Samaritan law. That's really important because we know that criminalization is not going to solve this overdose epidemic that we're seeing in our state right now. I do believe that. On the second point, unfortunately, right, ER physicians are so trained by now on how to respond to these overdoses because they see so many in their hospitals that this doesn't necessarily change the practice of care, right? But it does provide us with greater data, which is what we were discussing earlier, and it can empower patients with more information as to what drugs are in their body, which can help them in their decision-making. And not only their own decision-making, but what one of the ER physicians mentioned to us is that if she's able to tell a patient, hey, you have fentanyl in your system after they've been reversed, they can go back and share that with friends or people that they know that might have gotten drugs from the same source, and it could also be life-saving in that manner.
We have Delegate Morgan, followed by Delegate Lewis, followed by Delegate Rosenberg. Okay, wonderful. Delegate Lewis.
Thank you so much, Madam Chair. Thank you, Delegate Vogel. Thank you, Mr. and Mrs. Seams and Ms. Yates. My question is for the delegate. I'm interested in the opportunity that your bill provides to connect emergency room fentanyl testing with other harm reduction interventions. in 2017 or 2018, the Maryland General Assembly passed legislation to make fentanyl test strips available, like to decriminalize the test strips. I'd love to know more how that initiative is working. The fact that people who use substances are still dying of fentanyl exposure means that those strips are not reaching them. So I wonder if your bill, or they don't have access to the strips, they don't know they're available, I'm not sure what's happening. So I wonder if your bill opens a door for more comprehensive intervention, harm reduction, as well as emergency room testing.
Thank you, Delegate. And this is also a conversation that we've had with some of these ER physicians who rightfully believe that their hospitals are an important place to have that harm reduction intervention. And there's a lot of issues there that need to be addressed, and I do think that's hospital by hospital that they implement those programs. But distribution of test strips, right? If you have someone that tests positive after they've been reversed, and you can identify that and provide them with test strips or provide them with Narcan to take home with them, I know that's another issue that some of these hospitals are dealing with, the fact that now it is harder for them to distribute Narcan to patients at the hospital. Outside of the scope of this bill, but something that we should be looking into. But having that information on the fact that a patient could have fentanyl in their system could be really helpful at identifying which patients should receive some of those harm intervention practices.
My pleasure. Delegate Rosenberg.
Thank you, Madam Chair. The sponsor, I don't know if you're aware, or new members of the committee, we created last year an opioid Restitution Fund Advisory Council, which is both, glad I can see by your nodding heads that you're aware of it, that is an advisory panel of parents, people who've dealt with the issue, experts as well. Potentially, that's a place where the information, if we were to move your bill, that could be one of the places where we send the information so that they can analyze and respond based on this additional data.
I agree.
Great. Yes.
Thank you, Delegate.
Thank you.
Delegate Bandari.
Thank you, Madam Chair. To our chair question, I would also suggest to add some provision of the bill, I believe through amendment, regarding the outlining the appropriate use and handling of data obtained from the rapid urine drug test, including specifying who has access to data, how it is stored and secure, and how it is used for research or public health purpose, and how patients are notified of their test result, and what action are taken based on the result.
Well, thank you, Delegate, and I would be happy to work with you on the language for that amendment.
So we have two other oral witnesses. We're going to take them. Before we do that, I would like, Delegate, if you will get in touch with Delegate Callison. I have already spoken with her, and work with her to have the meetings that you need to have in order to amend the bill and talk to her about a possible solution. And then you can include Delegate Bandari as well, okay?
Yes, Madam Chair.
We have virtually Sam Bierman, and I want to thank both of you for being so patient and waiting, okay? We really appreciate it. We're kind of navigating this virtual real world, so thank you. So why don't you go ahead, start it, Sam, and then Ana Maria.
Thank you, Madam Chair. Hi, everybody. My name is Sam Bierman. I'm the Executive Director of Maryland Addiction Recovery Center. I am also a person in long-term recovery, and I've been on the front lines of the opioid epidemic for the better part of the last 20 years. Everybody has said a lot already today, so I definitely don't want to beat a dead horse, but a couple things that I do want to mention here is there are medical consequences to not testing for fentanyl during an overdose as well as post-overdose in the hospital. Some of those consequences in this example of Josh's case specifically, if he was rushed to the hospital and the hospital did their 5-panel test and he came up for cocaine and there was a chance to save his life, they would not know based on that 5-panel test that Narcan would probably save his life without testing for fentanyl as well. And that is far too common of a case that I see at our centers. The other really scary thing about fentanyl is that most people that come up positive for it don't realize that they do have fentanyl in their system, since it's being cut into so many other illicit substances. So in our center, and we keep the statistics, last year alone, we had over 500 patients that we treated that came up positive for fentanyl upon admission. Out of those 500 patients, a little bit over 10% of them were the only ones that actually expected fentanyl to come up in those screens. So about 90% of our patients that had fentanyl in their system didn't realize what they were ingesting had fentanyl in it. Post and overdose as well has medical consequences if we don't know fentanyl's in their system. It does have a different medical detoxification protocol than somebody that doesn't have fentanyl in their system. And the reason that is fentanyl has a much longer half-life than other opiates like heroin, OxyContin, and others. And so it has a much different medical response than other opiates. Thank you.
Thank you for your testimony and for sharing your personal story. Ana Maria.
Hello, my name is Ana Maria, and I support HB 811. As the last 7 years of my life and my families have been affected by fentanyl. In 2016, on Halloween night, my parents got a call from my brother who was away at college saying he was suffering with addiction to painkillers and heroin and had been since high school after needing 2 surgeries and sports injuries. Immediately, my parents picked him up and luckily they found a rehab right away. My brother's story is not mine to share, but how it has affected me is. He completed his first rehab and was sober for 2 years. Then we have our first rehab relapse. Once again, he comes to us for help, but this time has gone deeper as he has found fentanyl. Fentanyl is now his drug of choice. We need to get him help ASAP. He once again goes to rehab and stays sober for a long period and relapses again and gets sober again. Currently, my brother is in recovery for over 2 years. This does not take away the fear I have every single day and every single night in my sleep that my brother could go back at any moment and use fentanyl. And the reality is he could die if he did. In addiction, relapses are extremely common. And this is the reality for myself, my sister, and my parents. If we have fentanyl testing in every hospital in the state of Maryland, this would allow the data to be realistic and allow us to see the true numbers of this epidemic. This would allow for more help to families and those suffering with addiction. I currently work for a nonprofit called Love in the Trenches as an IT specialist. We have groups for those who have lost a child or sibling to addiction and support groups for those who have a child in recovery or active addiction. The groups are constantly full. We have to shut down the online form almost every time we open it. Last week, I opened it back up to submissions, and immediately within 24 hours, we received eight submissions from parents of ages 16 up saying their child had been fatally poisoned by fentanyl. This is not okay, and there's not enough resources for parents who have lost a child to fentanyl. I am so sick of waking up and hearing of another friend, loved one, family member, ex-partner, acquaintance, or friend of a friend dying from fentanyl overdose. I hope you give this bill a favorable vote, as it has the ability to save so many lives. Thank you.
Thank you for sharing your story. Are there any questions for these 2 witnesses? Seeing none, thank you very much. You have a blessed day, okay? And actually, this concludes the bill hearing on House Bill 811. Again, thank you for sharing your story, okay? Appreciate it. We have next Delegate Lewis. Delegate Lewis, you owe us dinner. You'll be the 3rd one. Okay? Oh, she owes us dinner too. We're going on to House Bill 489. Delegate Robin Lewis, Residential Service Agencies Reimbursement Personal Assistance Services. Will you be so kind and bring your panel, please?
Yes, ma'am. Thank you. Thank you, Madam Chair. Delegate Robin Lewis here on behalf of House Bill 489. Madam Chair,
Yes.
Madam Vice Chair, esteemed colleagues, I'm back. So we're going to talk a little bit more about residential service agencies. This bill is a healthcare worker rights bill. I really hope you'll support it. As you know, from not only from my previous bill testimony, but from the work that we've been doing here to tackle the healthcare workers shortage crisis, you know that residential service agencies provide a really important source of healthcare services. The folks who are employed by residential service agencies are RSAs. The personal care workers or home care workers come in two flavors. Some home care workers are employees of the RSAs. They receive W-2 forms at the end of the year. They may have access to a package of benefits. They're employees. Other home care workers at these agencies are treated as contractors. They get a 1099 form instead of a W-2, and consequently, they lack access to basic package of worker benefits more often than not. This bill addresses these problems, the problem of, first of all, disparate worker conditions and the lack of benefits for a certain class of workers. It aims to fix that by authorizing the Maryland Department of Health to only contract with and reimburse those RSAs that classify their home care workers as employees. This is a bill that prevents misclassifications of this important and vital class of workers, sets the scales in balance, and makes our healthcare workforce healthier, more likely to be retained. And I think it's a good thing, and I hope you do too. With that, I'll end my testimony, ask for your favorable report, and invite my panelists to have their say. Thank you.
Good afternoon, Madam Chair. My name is David Rodwin. I lead the Public Justice Center's Workplace Justice Project. We're very grateful to Delegate Lewis for sponsoring this bill. So this bill is about following existing law, being good stewards of public dollars, and supporting care workers and those they care for by improving the quality of home care jobs. When home care workers are wrongly classified as independent contractors, it is extremely harmful. They lose all the employment-based social safety net protections. I'll just highlight a few of them. There are many. Sick days, especially important when you have workers caring for people who might be medically vulnerable or have compromised immune systems. Workers' comp, a lot of injuries in home care because of all the lifting that workers do, and many others. They face a higher tax burden at the end of the year as supposedly self-employed workers, even though they're not. They're really employees. There's higher turnover. There's written testimony from home care agencies talking about when they made the switch from classifying their workers as independent contractors to employees, turnover dropped substantially. So you improve turnover issues when you properly classify workers as employees. It's also good for businesses who are doing the right thing and classifying their employees as employees, and you'll hear from some of those today. There's very broad support for this bill, sort of for me personally, a remarkable level of support. Normally there's some opposition from some folks, but I'm really happy that Minka is here today supporting the bill, and home care agencies are here today supporting the bill. We're in conversations with the Maryland Department of Health about the effective date. We hope to work those out in subcommittee. We're making good progress in conversations with them. And with that, I'll urge the committee to issue a favorable report. Thank you very much.
Thank you. Who would like to go next?
Thank you, Chair and Committee. My name is Jennifer Gibson, and I live in Charles County, and I've been a home care worker for 15 years, serving Baltimore and Montgomery counties. I enjoy the work I do because, of course, it's my passion, and I'm grateful that my elders taught me the importance of care work. However, home care workers need more support and protection in Maryland. Because of low pay, poor benefits, many of my colleagues have left the field for more stable, less stressful jobs. And by preventing worker misclassification, this legislation will reduce turnover and improve quality of care. Home care workers' misclassification means instead of being employees with full entitlement of a minimum wage and protections, we're classified as independent contractors. Many of us do not even know that we are misclassified until we start sharing our experiences of not getting paid overtime and for the time that we spend commuting between homes. I have learned quickly that I have to advocate for myself against these residential service agencies. Home care workers are so needed in this state, and without us, everything will fall apart. I've worked for 3 different agencies, and all of them are the same because they use our labor, but with little pay and benefits. Aiding and assisting someone in their most vulnerable state is important work. If agencies valued this work, they would not treat us with such disrespect. At first, I did not know that I was being misclassified. I had no clue the agency was underpaying me. If it wasn't for $11.99, SEIU and Public Justice Center, I would have not known this was illegal. This is a widespread issue and needs to be prevented. The state's public dollars are being used by agencies who are breaking the law and undercutting their staff. This practice of residential service agencies getting away with misclassification is wrong, and it's bad for workers. It's bad for patients, it's bad for the state, and it's even bad for agencies. That's why I urge you to vote HB 489. Thank you.
Thank you, Ms. Gibson. Go ahead.
Good afternoon. Thank you, Chair, and members of the Health Government Operations Committee. My name is Cynthia Neely. I live in Baltimore City, and I have been a home care worker for 2 years. I enjoy work I do. I enjoy the work I do because I have seen how elderly patients need support, and many families do not want to put their loved ones in a nursing home. When I lost my job during the pandemic, I decided to become a home care worker because I knew I would be supporting so many families who needed home care services. How can you expect us to stay in the field when we must face agencies that misclassify us and underpay us? I am here today to stop residential service agencies from misclassifying home care workers because of low pay and poor benefits. Many of my colleagues leave the field for more stable, less stressful jobs. By preventing workers' misclassification, this legislation will reduce turnover and improve quality of care. Many of us do not even know that we are misclassified until we start sharing our experiences of not getting paid over time or for the time we spent commuting between homes. I have a coworker who is filing a 1099 form instead of a W-2 who are not getting the full benefit of being an employee. This is a widespread issue and it needs to be prevented. Because I didn't have a car last year, I was taking transit, which is often unreliable, or catching Ubers. Our agencies do not accommodate us for commute time. Sometimes paying an Uber costs me a day's work of pay. Our labor is what helps so many Marylanders return to work while we care for loved ones. Our labor is essential. Workers' misclassification devalues our work. I urge the committee to pass HB 489 and push Maryland to protect our home care workers because care can't wait. Thank you.
Thank you, Ms. Neely. Delegate Lewis, I have a couple more members on your sponsor panel. Should we go to them, or do you want to go to questions first?
If it's all right, Madam Chair, I'd like my panelists to all deliver their testimony.
Okay, so we will
who's
hear
left?
next from Ms. Stoika, if she's here, Ms. Arakat, and Ms. Bresnahan, and that would be the whole sponsor panel.
Thank you. We have enough chairs.
You can pull up some chairs if you'd like. Maybe Mr. Rodwin, if you want to move out while they testify. Thank you.
You did great.
Good afternoon, Vice Chair Kelly and members of the committee. My name is Ioana Stoika, and I'm a policy advocate with the Job Opportunities Task Force, a nonprofit organization that works to expand opportunities to employment and advocate for low-income workers. As you've heard from prior testimony, when workers are misclassified, they lose out on all sorts of protections. But not only that, these workers are subject to a much higher tax burden than those classified as employees. Misclassification, in fact, is one way in which regressive taxation manifests. Compounding this injustice is that workers that are most affected are women, specifically women of color. About 90% of Maryland's personal care aides, in the case of this bill, are women, and 70% of them are Black. This bill is obviously good for workers, but we are also testifying as an organization that works directly with employers. In our line of work, we work to place our trainees in stable, higher wage jobs, and we develop relationships with businesses in the process. And this bill is also good for those businesses who follow proper classification procedures and who lose out when they have to compete with those that misclassify workers. And not only do businesses that do right by their workers lose out, but our state loses out as well. According to the National Employment Law Project, when workers are incorrectly classified, billions of dollars of payroll are never reported to state and municipal governments, resulting in lost revenue that further translates into fewer services provided for these low-income workers. Finally, and this is critical, this bill does not mandate a certain classification. It simply incentivizes it. Our state should not be subsidizing businesses that skirt federal classification laws and guidelines, that treat workers unjustly, and that engage in unfair competitive practices. This bill is good for workers, it's good for businesses, and it's good for our state. Thank you.
Thank you. Who would like to go next?
Good afternoon, Chair and members of the committee. My name is Lorraine Arcad. I'm the Senior Policy Analyst with 1199 SCIU. 1199 is proud to be part of a broad coalition called Caring Across Maryland, the voices of care workers, patients impacted by our broken long-term care system, and advocates are pushing to invest in quality care and to invest in our care workforce. Home care workers are the backbone of our economy. Through the Caring Across Maryland Coalition, our 1199 members who work at nursing homes and hospitals sat down with home care workers to talk about the ways low pay, short staffing, and high turnover are symptoms of a systemic flaw, one that allows agencies to prioritize profit over patients. Not only does turnover hurt patients, but it also overburdens the rest of the care team. HB 489 puts an end to exploitation through misclassification and business owners who profit from lower costs, all while our most vulnerable workers and patients suffer. The state needs better oversight of public dollars so that families across Maryland who rely on home care services receive reliable and consistent home care workers. Maryland used to have an independent provider program for home care workers in which the state was the fiscal intermediary paying workers. Though in 2014, the administration of Governor Larry Hogan abruptly canceled that program out of fear it could be held liable for workers' overtime and travel time wages. This left Maryland with only one other choice, which was the agency-only model which we are seeing now, in which Medicaid funds are provided to residential service agencies. The state provides little to no support for workers and is reluctant to hold agencies accountable. It's time to change the way Maryland approaches home care workers. 1199 SCIU urges the committee to protect workers and support common sense legislation that will bolster our care infrastructure. Thank you.
Thank you.
Good afternoon, Madam Chair and members of the Health and Government Operations Committee. My name is Tammy Bresnahan. I'm the Director of Advocacy for ARP Maryland, and we support House Bill 489. And members, I think you can see an overarching theme. What ARP is concerned about are people that are going into individuals' home, predominantly older individuals, making sure that they know who their worker is, how that worker is trained, what kind of, if they are an independent contractor, who's responsible for that person when they go into their home. If they get hurt, who do they contact? Who is responsible? If the worker gets hurt, are they eligible for workers' comp? Or is it the person's home that they're going into? Who's responsible for that worker if they're injured on the job, if they're an independent contractor? So we want to just, I think it is the General Assembly needs to know who these workers are, how they're paid, what they're paid, and who they're taking care of, because they're taking care of our most vulnerable citizens. So we ask you to support House Bill 489. Thank you.
Thank you. So that is your entire sponsor panel, correct?
Yes, ma'am.
Excellent. So before we go to questions from the committee, I see one from Delegate Chisholm. I will just remind the committee that this bill will go to subcommittee, and we have 30 witnesses left today. Delegate Chisholm.
Thank you, Madam Chair. I guess that should wait to tell me to hurry up. I appreciate what you do. I really do. I guess my question is this. Given all of the benefits that being a W-2 employee affords you, why would we need to pass a law to force people to opt for the W-2? And would you be open if RSAs had on their application before you became an employee, 1099 or W-2, an opt-in for them? This is what we can pay you as a W-2, or we can pay you as a 1099. If you're paid as a W-2, you get these things. If you get paid as a 1099, you get these things. And I ask because although there's not many opposed on this bill, I do remember this bill from a year ago, maybe a couple years ago, and we did have a long list of 1099 employees who wished to stay 1099 employees because of the flexibility it allowed them in doing this important work.
Thank you. I think I can handle this question. I think I can handle Delegate Chisholm's question. And I do thank you for your thoughtfulness. This bill is actually really simple. It doesn't force anyone to do anything. All it does is that it says the Maryland Department of Health shall only reimburse RSAs that for those employees for their workers who are employees. Remember, we're using our public dollars. We're stewards of the public trust and public dollars. And so we can make a decision how those dollars are spent. Medicaid dollars are public dollars, and we're just saying if an RSA is going to ask for public dollars, they use those dollars to pay employees, not contractors.
Absolutely. I don't see any more questions for this panel. We do have another panel of proponents, and one person signed up unfavorable. So let me call up the next panel of proponents, which starts with Dana Kaufman, Matthew Amon, Zinovi Fradlin, Jason Haffer, sorry you guys, I don't have my glasses, Vivian Boone, if you all can come up. And then we have a virtual favorable as well after this, and then one unfavorable. Whoever would like to get started, and if you can introduce yourself, I would appreciate it.
Sure. Thank you very much, Madam Vice Chair, members of the committee. My name is Dana Kaufman. I'm here on behalf of the Maryland National Capital Home Care Association, and we are in support of this bill. As has been said, these are public dollars. This bill only affects those residential service agencies that are participating in the Medicaid program. Given the requirements of the Medicaid program for the trainings and the certifications, we do think it is appropriate that the workers be classified as W-2s. We also think that it will be beneficial as we continue to work to stabilize our workforce and to grow our workforce to ensure that these individuals have access to the benefits that are afforded to employees. And with that, I will ask for favorable consideration. Thank you.
Thank you so much. Matthew Alman.
Thank you, Madam Chair. My name is Matt Alman. I am the CEO of Home Centris Healthcare, which is a Maryland RSA. Home Centris is Maryland's largest Medicaid provider. We're in 5 different offices throughout the state, and we employ about 1,100 caregivers. I'm also on the MINCA board, which Ms. Kaufman represents, and I'm the chair of the Legislative Committee. And I'm testifying today in favor of HB 49. And I thought rather than spend my time talking about the merits of the W-2 model, I'd talk about why HB 489 is necessary to help RSA agencies make the choice to go into a W-2 model. As you may know, Maryland's RSAs received a guidance document from the Department of Labor, the Attorney General, and the Department of Health over the summer. And I'll read you the first sentence from it. It says, Maryland's RSAs sometimes wrongly classify caregivers as independent contractors rather than employees. When this happens, it's called worker misclassification, and it's illegal, unquote. So with that document in place, you might ask, why do we need HB 489? And I'll tell you from my perspective as the chair of the Legislative Committee for MINCA, I've talked to both 1099 agencies, which are members, and some which are not members. And, you know, many of them view this guidance document as non-binding and simply a piece of paper. And I've heard some folks say until the Department of Labor sues them for misclassification, they will remain 1099s until that time. That shocked Minka, and we voted unanimously to support this bill for that reason, and it's also one of the reasons some of the bill sponsors have come forward. So that's really why I am here testifying today, that unless we put some restrictions on public funds, the 1099 agencies will continue. Thank you, and I ask for your support.
Thank you. Who would like to go next?
Thank you, Chair, members of, I'm sorry. Thank you, Chair, members of the Health Government Operation Committee, for the opportunity to testify today. My name is Vivian Boone. I live in Baltimore City, and I have been a home care worker for 35 years. I enjoy the work that I do because I have a heart for those in need. However, home care workers need more support and protection. Home care workers' misclassification means that instead of being employed with a full entitlement of minimum wages and protection, we are classified as independent contractors. Many of us do not even know that we're misclassified until we start sharing about not getting paid overtime or for the time we spent between homes. Because of low pay and poor benefits, many of my colleagues are leaving the field for more stable jobs, less stressful jobs. By preventing misclassifications, this legislation would reduce turnover and improve the quality of care. I work hard for my money, but I'm not getting what I work for. It hurts me, it hurts my family, it hurts my home. I work to pay my bills, but when the agency misclassifies me, I work weekly to pay my monthly bills and still can't meet them. It's hard to make ends meet when you're not compensated justly. This is a widespread issue and it needs to be prevented. The state public dollars are being used by agencies who are breaking the law and undercutting their staff. Our governor, Wes Moore, said no one left behind. Home care workers continue to be left behind because of lack of state oversight. We call on this committee and the Department of Health to stand with home care workers. I respectfully ask a favorable report on HB 489. Thank you.
Thank you. Who's next?
Thank you.
My name is Zinove Frodlin. I am an owner administrator, Home Care of Baltimore. And thank you for the opportunity to provide my testimony in my support for Bill 489. I'm speaking from my personal experience. For the last 12 years, I have been managing residential service agency. And in 2019, our agency was audited by Unemployment Department and Labor Department. Both have their own rules, but both have ruled that care providers should be classified as employee and not independent contractors. Another, it's IRS. IRS has 20, everybody knows, IRS has 20 questions that can be used if somebody should classify it as 1099 or W-2 employee. I would only like to highlight two of them. If person is getting paid by hours, it's no question, it's company employee. If continue relationship with employer, it's again, no question, should be company employee. So we have to follow those rules. Both of those clearly apply to all home care providers, and they have to be classified as W-2 employee. In 2020, we have gone through the process of conversion. Our workers from independent contractors to employee using voluntarily classification settlement program. Program developed by IRS allow employee without any penalty reclassify their workers from 1099 to W-2. If Bill HB 0489 will be passed, Maryland's and healthcare business will be happier and will have more stable workspace and will provide better quality care. Thank you.
Thank you. And finally,
Thank you, Madam Chair and Committee. I'm going to spend, my colleagues have spent a lot of time talking about the benefits to employees, and I should introduce myself. My name is Jason Hafer. I work with Matt Allman at Home Centris. I run our personal care division, which is our RSA division with, as Matt said, over 1,100 employees. And they are employees, and they're employees for not only the reasons that we believe it's the right way to classify them for their benefit, but it's the right thing to do for our consumers as well. One of the hallmarks of being an independent contractor is that your agency doesn't tell you when to work, how to work, they don't provide training, they don't give you the instruction and the oversight. You're an independent contractor. You're expected to be able to manage that care for that client as if you're your own business. And let's face it, so many times home care workers don't have the resources to be able to do that. When you classify a home care worker as an employee, you provide them the oversight, the coaching, the training, the development opportunities. In our organization, we use lead caregiver programs, and we offer voluntary certification programs. We offer all kinds of training and development opportunities that if our caregivers were independent contractors, we simply couldn't provide to them. We pay overtime and all of these things that we talked about before. But at the end of the day, it's the right thing to do for the consumer, because when an independent contractor doesn't or isn't able to go to work for a day, who's responsible for backfilling that shift if they truly are their own business? I don't know. And at the end of the day, none of us would want that to be the care that our loved one receives. So the agency, in the agency model, the W-2 model that we employ, we're responsible. We ensure that if a caregiver needs additional coaching, training, development to be able to effectively provide care, we can do that. We ensure that if they need a week off to take care of an emergency at home, we have the back. We have their back, and we have the back of our clients. And at the end of the day, HB 489 just makes sure that we deliver the best quality care to the most vulnerable populations all over the state. Thank you.
thank you so much to the panel for your testimony. Do we have questions from the committee? Well, I am really appreciative for your testimony today. We've been talking about this issue for a number of years in this committee, so thank you.
Thank you.
We have a virtual, did you have a question? Oh, sorry, Delegate Alston. Sit down, Delegate Alston has a question.
I'm sorry.
No, you're welcome to.
And whoever could answer it, I just needed to know if the residential service agency includes small home-based businesses that provide, that are like assisted living. Would that be considered one of these agencies? So these are agencies that are sending people out to work. Okay, thank you.
Great, thank you so much. So now we will move to our virtual witness, who is Christopher Meyer. Hopefully we have him. Do we have him? Excellent. Go ahead and get started. You're ready. Are you ready, Mr. Meyer?
Apologies, I was trying to close the YouTube window. Thanks once again to the Chair, Vice Chair, and Committee. For the record, my name is Christopher Meyer. I'm a research analyst at the Maryland Center on Economic Policy. We support House Bill 489 because it would guarantee bedrock protections to home care workers and strengthen this workforce in the long run. The committee has already heard about the home care labor shortage, the importance of job quality, and the outsized harm done to women of color. Misclassification also increases pressure on the state budget. Home care workers are care experts. They're not tax experts. When I'm feeling generous, I might characterize myself as a tax expert, but I'm very grateful that payroll handles withholding for me. Misclassified workers aren't so fortunate. Ending Medicaid misclassification would put the complexities of tax administration back in the hands of trained professionals. That's good news for both workers and the state budget. It would ensure that income taxes are accurately withheld. It would stanch one source of revenue loss, and it would protect workers from inadvertently accumulating tax debt. Let's also be 100% clear. House Bill 489 does not preclude flexible arrangements between employers and employees. Employers and employees can, and very often do, work together on scheduling and other decisions to meet both parties' needs. The bill simply ensures that agencies receiving state funding acknowledge the employment relationship that in most cases already exists. House Bill 489 will make it easier to meet Marylanders' home care needs. Ending Medicaid misclassification will guarantee workers better protections, make home care jobs more attractive, and ultimately strengthen the workforce. For these reasons, I'm respectfully asking for a favorable report. Thank you.
Thank you, Mr. Meyer. Any questions for this witness? Seeing none, thank you for your testimony. We will move to the one unfavorable witness, who is Alex Pachukov. Thank you. Hope I got your name right.
Okay, thank you. Thank you, Madam Vice Chair. My name is Alex Patukov, and I am a partner at a small residential service agency.
If you could speak into the mic, I think it would be
I'm a
helpful for the
partner at
video.
a small residential service agency in Montgomery County. Thank you all for being here, and thank you for letting me speak. I appreciate your service. I know this is not hard. This is not easy to sit in front of testimonies all day long, so I appreciate it. You have my written testimony in front of you. I urge you, please read that. I will try and just speak from my heart this afternoon. We've been in business since 2002. It's a family-owned and operated agency, as many of them are. I was the first caregiver when we started, and I've worked my way up as a managing partner in this home agency. Over the years, we've seen many trends in employment law, and now we're seeing a trend to push agencies to change into a W-2 model. I just want to clarify and urge that there is nothing illegal about what we're doing. We've been doing it this whole time. There are 1,200 RSAs currently in Maryland. About half of them are 1099 model. It's actually offensive to say it's illegal and unethical. We've been doing it for a long time. We have been audited by everybody under the moon every other year, over and over and over again. Caregivers love to work as contractors. They come to our agency looking for that type of job. They like the flexibility to be able to pick their client, be able to pick their location, their time. Most of our caregivers work W-2 full-time jobs somewhere else as professionals and care for their loved ones in the evenings. They come in there and help them get ready in the morning. They come back in the evening, and they can do that through the waiver programs, through an agency. An agency is responsible, right? They're not on their own, running, shooting, doing whatever they want, right? We're licensed, insured, and bonded, right? We have workers' comp insurance for our caregivers. When they want to go on leave, we get substitutes, right? We give them raises. We do profit sharing at the end of the year, right? Our caregivers love us. We don't mistreat them, right? So a couple of misunderstandings. Well, I'll end with that. I invite any questions. Thank you.
I see a question from Delegate Lewis. Go ahead.
Thank you, Madam Chair. It sounds like you wanted to say a little bit more. Could you tell us what it was you wanted to say?
Sure. Thank you, Delegate Lewis. I appreciate that. So there's a misunderstanding thinking that if caregivers are W-2, they're paid more. That's a misunderstanding. It costs agencies much more for the overhead for W-2. When caregivers paid as a contractor, they're paid a higher wage. They get to keep all their money. At the end of the year, they go to see their tax professionals. And after all the deductions for traveling and all these different products that they use, right, during COVID, they had to buy some things, we couldn't get to them. After all the deductions, they pay a tax, right, or they pay their taxes. Often, it's much less than if they took the whole chunk out of their check. They appreciate that. You know, as you guys know, money is worth more upfront now rather than later. Caregivers typically are not wealthy, right? They're doing this because of lack of education, because a lot of them are immigrants, and a lot of them like to actually care for the elderly. And so this isn't a mistreatment of people. This isn't discrimination or minority versus majority topic. This is we do a good job to take care of our people, and they come to us for that. There's a lot of agencies on our side. There are moms and pops agencies. They don't know about this bill. And some of my colleagues on MINCA, that's been mentioned, also do not support this bill. It is not unanimous. Thank you.
Are there any questions? Delegate Alston, then Delegate Johnson.
I'm just wondering if this bill were enacted, what would be the financial effect to your company?
Thank you. Very good question. So most of the agencies are not huge, right? We'd have to retrofit all of our software. We would have to re-sign contracts with caregivers. Inevitably, they would leave, right? You keep hearing over and over again about a shortage of caregivers, right? This would essentially push caregivers out of this particular niche of the industry, right? If you can't be a contractor and go from client to client, all of a sudden, what stops you from going and being a W-2 anywhere else, right? You can go work at a senior facility, at a hospital, right? So this would put strain on having to set up all of new contracts, having to set up software, having to re-recruit new people who want to work as W-2s. I mean, there's an endless list of costs.
Delegate Johnson, followed by Delegate Hill.
Thank you, Madam Chair. If you went to W-2 employees, wouldn't one of those costs be you would have to then pay Social Security and Medicare for your employees?
Yes, Delegate.
Thank you. Thank you, Madam.
My pleasure. Delegate Hill.
Thank you. So you heard the earlier testimony, but you also testified that it comes out equal so that when you're paying your contracted employees, you're paying them a higher wage so that they can pay the Social Security and all that out of it. So the question I have is, why is this not just, I mean, there are bad actors, you're not a bad actor, I get that, but why is this not the right thing to do to make sure that everyone's getting paid? Because
Sure.
your employees can still work for you under W-2. They're not going to not work because of that, right?
Well, technically, you shouldn't treat within the same agency an employee, the same kind of employee in two different fashions. That's slippery slope, right? You either do one or the other, okay? Why shouldn't we do this? We should have freedom of market. We should let, for example, some agencies have testified that they do W-2, right? For example, one of them were buying 1099 agencies, many of them, small ones, right? Because they were a good market, right? Since then, they got cold feet. I assume it's because they want to bundle it up and resell it on the stock market, right? But for example, they want to sleep peacefully at night. They don't want the liability of anything that could happen from misclassification. They can have their choice to change to a W-2 model, but you shouldn't have to force everybody to do it, right? There are already laws on the books that say what you should and you shouldn't do. If everybody just follows those laws, you won't be in trouble like us. Follow the existing laws, pass something that says, hey, if you don't follow laws, you can't have Medicaid money. Simple. You're welcome.
Any other questions? Delegate Guzzoni.
Chair, sorry.
Okay.
I'm not giving you a raise yet. So I'm curious, you made it sound like many of your employees, if not most of your employees, are working, this would be their second job.
Yes, ma'am.
And that they're working presumably in most instances as a regular benefited employee someplace else.
Yes, ma'am.
So does this also mean that most people are part-time and not working?
Yes, absolutely. Yes, absolutely. A lot of them are part-time. Some are full-time, and we pay overtime for the ones that are full-time. So there's, you hear sometimes that you don't get paid overtime. Well, you do if the agency pays you, right? So I mean, it's a separate question, right? Pass that law. But this is Medicaid money. You're welcome.
Thank you. Delegate Vandari.
Thank you, Madam Chair. I read your testimony, and you have mentioned the bill does not have much support. I have a question. Should the support for a bill be based on solely on the number of people who are aware of it or support it, or should it be based on its potential benefits and merits? And another point you raised was caregiver prefer to work as 1099. Is there evidence to support the claim that all caregivers prefer to work as 1099 contractor, or is it possible that some may prefer the stability and benefits of being an employee?
Sure. Thank you. Good questions. Sure. Perhaps some do, right? The ones that call our agency want to be contractors. I don't have any data that says some want W-2, some do not. I can just tell you about us, our specific experiences. Caregivers love it. That's what they want. I'm sorry, what was the first question?
You said that the bill doesn't have much support.
No, I'm sorry. I said the bill does have support. Does not have a lot of opposition. Well, it's a lot of moms and pops agencies, right? They're not part of MINCA, right? This National Home Healthcare Association, right? A lot of them are, have 10, 20 clients, take care of their population. A lot of them are out, in some rural industry, in some rural area, right? And they just have a few caregivers and a few clients, right? This isn't about what the large agency want, right? This is about community help, right? We're in different communities all over the state, right? And kind of work in little pockets. I hope that answers the question.
You want to follow up?
Yes. I was talking about potential benefits and merits to the workers.
Say that one more time.
In a long run, the potential benefits. When you're in W-2, you heard some of the testimony, very emotional testimony.
Sure.
Yeah.
So some of the benefits that were brought up that could be for a W-2 worker are training, right? We already have laws for RSAs for training, right? We have nurses come out and do quarterly assessments on the caregivers, on the clients, make sure that they could provide the care that the client needs, right? They're not just out there doing whatever they want, right? These are CNAs, certified nursing assistants, home health care aides. These are professionals in the business, right, that can help their needs. Sometimes they're a family member, right? And what they're doing for their loved one are holding their hand while they're going to the bathroom, right? You know, this isn't dangerous work, right? Sometimes they're medication reminding, right? Medicaid allows families, clients to help them as well. So a lot of times, and especially during COVID, a lot of the clients were scared of the caregivers, right? They would ask us, does your caregiver have kids at home? Because we don't want a caregiver with kids, right? That's how radical it became, right? And so a lot of the clients' caregivers are their family members. They come in there, they help them, they supplement their income, everybody's happy.
Thank you. Based on your testimony, therefore, these workers need the protections. I think you agree on that. Thank you.
Okay. Delegate Hutchinson.
Thank you, Madam Chair. Just so I understand this correctly, if this legislation passed and you were forced to change to W-2, will that put you out of business, and would that put other small mom and pop?
It very well could. Thank you, actually. That's a great question. It very well could. I'm not sure, you probably are familiar. Medicaid reimbursement rates are low, right? There's not enough money. There's a huge waiting line to get onto the program, as you heard a few bills ago, right? The reimbursement rates are low. For example, Medicaid reimbursement right now is at $23 an hour, I believe, right? On a private market, if you want to go hire a caregiver, it's 50% higher, right? Because it costs that much more, right? So $23 an hour, right? When you have to go to W-2, your costs go up substantially. Your profit margin drops dramatically, and you could flop all over the state. Thank you.
My pleasure. Any other questions? Seeing none, thank you very much for being with us today, and thank you for doing business in our state.
Thank you for your questions.
Our pleasure. This actually concludes the bill hearing on House Bill 489. For the committee's planning purposes, we have two more bills left. There are a lot of witnesses. House Bill 814, House Bill 588. House Bill 814, Delegate Kirk, can you please bring your panel?
Thank you, Madam Chair. My panel, Johanna Fabian Marks, Neil Bergman, Stephanie Clapper, Jake Whitaker, and Michelle Everly.
Thank you.
Okay, good afternoon, Madam Chair.
Good afternoon.
I'm here today, Delegate Ken Kerr, with House Bill 814. It's the sunset repeal of the Maryland Health Benefit Exchange youth adult subsidies that we passed a few years back. There are 16 witnesses here who are motivated to come today and speak to you about the success and the importance of this program, and to make the case for the repeal of the sunset. So I think it's best if I just get out of the way and let you hear from them.
Thank you. I appreciate it. And I know you're about to start, but after like the fifth or sixth witness, if you have a Me Too, the committee will love you for it. Okay? Go ahead.
All right. Thank you, Madam Chair, Vice Chair, and members of the committee for the opportunity to testify in support of HB 814 today. I'm Johanna Fabian Marks, Director of Policy at the Maryland Health Benefit Exchange. To help with time a little bit, I'll be the only one testifying from the exchange, so Michelle's going to sit this one out. As you know, this bill would remove the 2023 sunset on the Young Adult Subsidy Pilot Program administered by the exchange. That pilot was implemented following recommendations of a stakeholder work group that recommended targeting subsidies at young adults because they account for nearly half of uninsured, non-Medicaid eligible people in the state. And when healthy young folks enroll, everyone benefits as it strengthens the risk pool. Also, the reinsurance program, even though it has been very successful, is not effective at reducing premiums for lower income folks. A direct state premium subsidy like the pilot is far more effective. Our first year of results indicate that the program is indeed leading to more young adults to get and keep coverage. Our year-over-year growth in young adult enrollment increased by 11%, the largest increase in the last several years. And on top of that, our young adult enrollees were less likely to drop coverage during the year. In 2022, the program reduced more than 45,000 young adult premiums by a third on average. That's a big impact for a program that cost about $14 million. I also want to highlight the health equity impact. Young adult subsidy recipients were more likely to be Black and Hispanic, and they tend to be uninsured at 2 to 3 times the rates of white young adults, so that's a particularly exciting outcome. Last thing I'll mention is that this pilot launched during COVID when Medicaid terminations were halted. So we estimate that there's about 22,000 young adults still in Medicaid who could roll off when terminations start and would be eligible for private coverage through the exchange. This subsidy would help ensure that there's affordable coverage for them. Thank you.
Thank you. Next, please.
Thank you. My name is Stephanie Clapper. I'm with Maryland Healthcare for All. I'm also testifying for Len Lucci, who will not be here today. The Maryland Healthcare for All Coalition is made up of over 300 faith, business, labor, community, and healthcare organizations across the state, all working towards quality, affordable healthcare for all Marylanders. We strongly support this legislation, and I especially want to thank your committee for your leadership in making sure that over 400,000 Marylanders have been covered since the passage of the Affordable Care Act. It's thanks to innovative programs like the 2-year youth subsidies pilot that passed out of your committee. It's been extremely successful. About 45,000 young people in Maryland in 2022 were able to get coverage using these subsidies, including 17,000 who were new to the market. Not only does that mean that 17,000 young adults were able to get coverage for the first time through the marketplace, it means that the young adults who were already getting coverage were able to better afford their premiums. They were more likely to pay their premiums month to month and remained on coverage. They also were able to upgrade to better plans that had lower cost sharing, lower deductibles, lower co-pays, lower co-insurance, and that can make the difference between a person being able to actually use their health coverage or not. As Johanna said, it was able to help reduce health disparities, and in 2023, Latino young adult enrollment grew 13%, which was more than any other population. With the unwinding of Medicaid through the end of the public health emergency, this program is more important than ever. It's a good use of state dollars. It's very efficient since young adult coverage tends to be less expensive than other groups, and it is helping to stabilize premiums in the individual market. Thanks to your leadership, Maryland has one of the top 5 healthcare systems in the country. We should continue to lead. I urge a favorable report on House Bill 814.
Thank you, and thank you for your work. You have been a true partner. Next, please.
My name is Neil Bergsman. I'm the Senior Policy Analyst for Maryland Nonprofits, the statewide network of all nonprofits with more than 1,700 members. Maryland Nonprofits supports House Bill 814, and I think I'll come in under a minute. Improved health outcomes and quality of life and reduced disparities in health care are goals that are of interest to Maryland's nonprofit community. This bill will help our qualifying employees and the clients of our nonprofit organizations. You were smart to authorize this subsidy on a trial basis. The trial has been very successful, and you should make it permanent. And what Joanna and Stephanie said about health outcomes, stabilizing premiums, racial disparities, and the Medicaid cliff. For these reasons, we request a favorable report. Thank you.
Thank you for your work as well. Next, please.
Thank you, Madam Chair and members of the committee. My name is Jake Whitaker. I'm Director of Government Affairs at the Maryland Hospital Association, here to testify in support of House Bill 814. I couldn't have said it better than Delegate Kerr or the rest of the panel, so I'll just say me too.
Oh, fantastic. Thank you. And I want to tell you thank you on behalf of the committee. I know, Michelle, you're not going to testify, but I do want to thank you on behalf of the committee for all your work that you have done over the years. You are really amazing. Thank you very much. So now we're going to open it up for questions for this sponsor panel. Are there any questions from anyone? Delegate Collison, followed by Delegate Morgan.
Thank you, Madam Chair. Johanna, I'm sorry, I wasn't writing fast enough. Can you give me, and I know we have this data someplace else, but I'd like to hear it again. How many young adults have enrolled? Have you seen an increase over the years in terms of who's enrolling, and you made reference to the amount of premium cost that you think has benefited them. Can you just run through those numbers for me again?
Absolutely. So yes, in 2022, we had young adult enrollment of approximately 50,000. That was up about 5,000 from the prior year, which was a really significant growth. We haven't seen growth like that in years. And the effect of the subsidy was to reduce young adult premiums by about a third. So they were paying roughly $100 on average before the subsidy, and with the subsidy that went down to about $70.
Okay, great. Thank you very much.
You want to follow up, or you're?
No,
You're fine?
good.
Okay. And I only did that because the bill goes to her committee. Delegate Morgan.
Yeah, real quick, this question is probably for the delegate. This is the program that deals with reinsurance, right? It takes a portion of that reinsurance fund and directs the subsidies for young people. I forgot, do you know approximately how much money is in the fund? And also, is this subsidy for young people, is it based on age, or is there any type of income requirement? And when does that cliff cut off? Is that 30? When does the subsidy get whacked because of age?
It does come from the reinsurance fund. We allocated up to $20 million a year. I think the highest we've gotten is about 17. And it is age. It's age 18 to 34. And it's also up to 400% of poverty, which for an individual would be about $51,000. Family of three, somewhere around $100,000.
My pleasure. Any other questions? Seeing none, thank you so much for your testimony and for your work. We are now going to go on to Jana Barwick. And Kenneth Phelps, Sarah Bird, Lead Hudson. Will you all come up, please? And Allison Taylor. You can get started.
All right. My name is Jana Varwig. I'm here to advocate for the continuation of the pilot youth subsidy program supporting health insurance for young adults. And before the state enacted the pilot youth subsidy program, many young people working for small nonprofits or small businesses or doing gig work did not have access to affordable health care or affordable health insurance. And my son is a case in point. Like many young adults, he is working for a small employer in the food industry who does not offer health insurance. Prior to the youth subsidy, at our urging, our son found a policy on the Maryland Health Connection. Now, that provided some very basic medical care. However, it had a very high deductible, meaning that he would be responsible for paying most of his medical costs up to $6,000. If he had become seriously ill or injured or ended up in the hospital, he would have incurred $6,000 of medical debt, unaffordable for him and for most young adults who are in entry-level positions. The high cost of that deductible made him very hesitant to access health care. He didn't want to go to the doctor when he wasn't feeling well. In a pandemic, you can imagine how his parents felt. And he was probably right. He would have incurred, substantial debt. When the youth subsidy pilot program went into effect, however, he found another policy that had a much lower monthly premium and a much smaller deductible of $2,000. And he had more medical services available to him. And we saw our son start to use medical care, which was a real relief to us. As a retired dean of students in higher education, I have to say that young adults do have accidents, they do get sick, and they need access to care at this time. And so I urge you strongly, on behalf of all these working young adults, that you continue the youth subsidy for health insurance.
Thank you for your testimony today. Who will follow?
Madam Chair, good to see you again, members of the committee.
Nice to see you.
I'm Ken Phelps. I represent the Episcopal Diocese of Maryland. Just again, for the record, the Episcopal Church, not just the diocese, sees healthcare as a human right, and anything we can do to expand coverage and access is great, and extended Me Too. My sons went into business for themselves in their 20s before there was an exchange and when they were ineligible for Medicaid. And they struggled mightily, but were able to, build a successful business. But I know how much this would have helped them. And so I urge you just on that to, support this bill. We request a favorable report. Thank you.
Thank you. Love the short testimony. Next, please.
Madam Chair and committee members, my name is Sarah Burr. I'm from Baltimore City. I am also a mother of a young adult who has benefited from the youth subsidies. My son is a chef. He makes $15 an hour. There are no health benefits. Under the youth subsidies, he's been able to, he pays half of his income in rent. Under the youth subsidies, he's been able to get health insurance for $55 a month with a good HMO. He has a chronic health condition. All his physician visits are covered. He has an affordable medication. And so many young adults, they're struggling. It's tough to live on $10, $12, $15, $20 an hour. And I strongly encourage you to continue this program. Thank you.
Thank you for your testimony and sharing your story. Next, please.
Yes, Madam Chair, members of the committee, my name is Lee Hudson. I'm with the Evangelical Lutheran Church in America here in the state of Maryland. We were thrilled to support HB 780 of 2021. We hear it's doing what it was supposed to do. So our testimony is us too.
Thank you so much. We love that. Are there any questions for this panel? See, we return it in kind. Thank you. Next, we have Allison Taylor, Lorraine Aricott, Len Lucci's not here, and Brett Leninger.
Thank you, Chair. Wait.
You can go ahead.
Okay. Thank you, Chair and members of the committee. I'll keep my testimony brief. My name is Lorraine Aricott, Senior Policy Analyst at 1199 SCIU. 1199 supports policies like HB 814 because it helps expand healthcare coverage to more Marylanders, which therefore creates healthier communities. By prioritizing prevention and access, it helps our healthcare workers who are currently navigating a staffing crisis to be less overburdened by patients who had barriers to care. And with that, I'll do a big Me Too, and thank you, sponsor, for stewarding this bill.
Thank you for your leadership. Are there any questions for this witness? Seeing none, thank you very much. Once again, Allison Taylor, Brett Leninger. Okay, Allison Taylor is not here. She's Me Too? Okay, great. So now we're going to go to virtual testimony. And if you will be so kind and just bring them all. Thank you. And for the committee, these are all favorable, all three. And after we're done with these three, it will conclude the hearing, and we will go on to our last bill of the day. While we wait, we will be having a meeting of the weekly review committee in the conference room, please. Immediately after the hearings. Good afternoon. How are you? You can unmute yourself and you can get started. Go ahead.
Can you hear me?
Yes, go ahead. Thank you.
Okay, great. Hi. Good afternoon.
Good
Thank you,
afternoon.
Madam Chair, and members of the committee for the opportunity to testify today. I'll be super quick. My name is Sheena O.G. I am a graduate student at the University of Maryland School of Social Work. You've already heard some great testimonies and some great stories, so I'd just like to share that this young adult health insurance subsidy, they are absolutely crucial for those of us that do suffer from chronic illnesses and simply cannot afford to not have health care. So I do urge a favorable report for HB 814. Thank you.
Thank you. We love the short testimony, and thank you for being here with us. Next, please.
Hi, my name is Pastor Sandra Connor. I represent the Baptist Ministers Night Conference of Baltimore Vicinity, and I am entering a favorable vote for HB 814 for the health subsidies for youth and young adults. For me, I think it's challenging just to have someone enter into adulthood at age 18 to begin with, and then to be between the ages of 18 and 34, just trying to figure out how you're going to navigate, how you're going to manage, and do all those things that you need to do to become self-reliant and self-sufficient. I think of all the things that can impact them, the social determinants of health, unemployment, healthcare, social issues, physical issues, and all the things that can affect young adults, not alone just young adults, but everyone. And I'm thinking that if we could mitigate and remove healthcare as one of their challenges, I think that that would be a great thing for us to do. So I'm voting favorable for asking you all to pass this bill for a favorable motion for it to pass so that they can get the subsidies required to have it extend beyond the current trial period.
Thank you. Are there any, and thank you for your testimony today. Are there any questions for these two witnesses? Seeing none, thank you for being with us. We do have one more witness. Hi, will you be so kind and unmute yourself and you can get started.
Hi, good afternoon. My name is Mukta Bain. Thank you, Chair Kania Malik and the Health Organization community members for allowing me to testify in support of House Bill 814. As a young adult, I do urge you to support this bill. I'm lucky now that I can choose a health insurance through my workplace, but not all Marylanders are as fortunate. Young adult age 18 to 34 comprise Maryland's largest uninsured age group. It was terrific to see Maryland started a subsidized program to make health coverage affordable for young adults. In 2022, about 45,000 young Marylanders have used the subsidized to enroll in insurance coverage, including over 17,000 new to the marketplace. But it wasn't like this before. I'm thankful for Medicaid coverage because I was stressed about paying for my medications and seeing healthcare providers. Everything changed when I started working for Baltimore County Department of Health. I was hired as a contact tracer, but they did not provide us health insurance because we are contractors. So I was in a dilemma. I didn't have any appropriate option to choose a health plan when I went to Maryland Health Connection website. Either the premium or the deductible was too high. For some listed health plan, the premium was higher than my rent. So I was in a situation of having to choose either pay for my rent or my health care service. If young adults don't have health insurance now, their health problem will increase definitely. Maryland should continue to set an example for other states to help residents access to affordable health coverage. So please, I urge you to support this bill.
Thank you for being here and thank you for getting insurance. It's important. Are there any questions for this witness? Seeing none, thank you so much for being with us. We appreciate your testimony. This will conclude the bill hearing on House Bill 588. Next, we have the last bill hearing, House Bill 588. Actually, I'm sorry. This will conclude the bill hearing on 814. Next, we have House Bill 588, Delegate Collison, Health Insurance Qualified Resident Enrollment Program Access to Care Act. Will you bring your panel for House Bill 588, please? And as soon as you sit, if you will be so kind and start giving your testimony. After the fifth or the sixth witness, if you can say me too, that would be wonderful. Thank you very much.
Thank you, Madam Chair. And again, we're not quite evening yet, I don't think. I appreciate your time and attention to HB 588, Qualified Resident Enrollment Program, otherwise known as the Access to Care. So we've made a commitment in the state through various programs, one you just heard about, to try to make sure that every single person who lives in Maryland has health care. because we believe, as a state, we've shown that in our policy over and over again, that that is an important human right and that we need to provide it for all of our residents. This bill is just the next step to getting us to that goal. And, you know, like the bill that I brought to you last week, where we're studying, you know, all the different programs that we have and how do we open access. And again, it's a study. This bill is the next step in terms of using the resources and programs that we have. So we're not changing, you know, we're not making major changes in how insurance works, and we're not, you know, making changes in who gets paid and how is it paid. All we're doing is looking at the programs that we have and making them as accessible and affordable as possible so that we can reach that goal. The bill, from my perspective, respects and values every Marylander who's seeking equity in healthcare. We have been committed to equity in my entire tenure in this body. We've made a promise to our residents when we created the Commission on Health Equity and the Health Equity Resource Communities in 2022. We got part of the way there with the Healthy Baby Act, providing health coverage for pregnant women and their babies. This bill takes it a step further. But this bill isn't just about a moral obligation, which we can talk about offline, but I think it's a win-win-win proposition for everyone. First of all, for those who are currently not eligible to participate in our healthcare exchange, those are folks who due to their immigrant status, they do not have full citizenship, then those are the folks who are now prohibited from participating in our healthcare exchange and the ACA programs. So those folks are going to benefit because they will get some of the most affordable healthcare plans in this country. They'll have access to preventive care, and they can stay healthier. And I looked at some research that was provided by the Kaiser Family Foundation, and it found that the expansion of healthcare coverage through the ACA improved not only access to care, but consequently financial security and overall health outcomes. This is especially beneficial for children in these immigrant families who tend to be disproportionately uninsured. So it's a win for the families. The amount of money that the state pays in uncompensated care will be decreased in this way as well. So it's a win for the state. And healthcare premiums. Now, you know, I'm learning about insurance, and the way we keep premiums down is to keep our pool healthy. And the bigger the pool and the larger number of healthy people, that our premiums are sustained or their increases are smaller. They're more stable when we can have a large, healthy pool. That's a win for all of us. So it's win, win, win. HB 588, what it does specifically is say that the Maryland Health Benefit Exchange and the Department of Health will request a waiver from the federal government to allow us to open our healthcare exchange to our undocumented immigrants. And this has already been done in the state of Washington. So that says to us they are open to this notion of expanding access. I'm very happy to have the support of the Legislative Latino Caucus on this bill. You will see a number of written documents, and you will hear probably from some people about amendments. Most of the amendments in those documents that you're reading about are to ensure parity in subsidies. If funding is available, and the bill says upon availability, and this program is implemented, then what they're asking for in these amendments is that there is parity among all participants in the exchange, and that there aren't differentiated subsidies depending on immigration status. You know, like I started off with, we made a promise that we believe in health equity and that people should have access to health care. Let's help move that promise forward by looking at this legislation and reporting favorably on it. Thank you very much for your attention and your time, and I'm going to turn it over to people who know much more than I do. And Michelle, you want to go first?
I'd be happy to. Good afternoon, Chair Pena-Melnick and members of the committee. Thank you for the opportunity to testify today. I am Michelle Eberly, and I have the pure joy of serving as the Executive Director for Maryland Health Benefit Exchange. Maryland's uninsured rate has fallen in half in the last 10 years. With your support, the state has been a national leader in working to reduce the uninsured rate through our innovative initiatives such as the reinsurance program, the easy enrollment, and the young adult subsidy program, which you just heard about. Even with those programs in place, over 300,000 individuals remain uninsured, and undocumented residents comprise 1/3 of that number. This bill establishes an enrollment program for populations who are currently ineligible for coverage through Maryland Health Connection. The impact of providing this coverage for all Maryland residents is significant. You heard a little bit of that from Delegate Cullison. Not only will it improve the overall health of our state population due to increased access to care, while at the same time decreasing costs for hospitals that provide uncompensated care, but it will also increase the size of the individual market pool, which typically puts downward pressure on premium rates for everyone. In 2021, the exchange submitted a joint chairman's report that contains a detailed actuarial analysis for a waiver and subsidy model that would provide coverage in private plans through Maryland Health Connection for qualified residents. It's important, however, for this committee to note that establishing the qualified resident enrollment program is not contingent on the availability of state funds. We are prepared and ready at this moment to file an amendment to our 1332 waiver that would allow individuals to access coverage through the exchange and avail of subsidies that already exist, such as the Young Adult Subsidy Program. However, the magnitude of enrollment would be much larger with additional funding. And with that, I request a favorable report for this bill.
You want to go? Sure.
Chair Pena-Melnick and members of the committee, my name is Michelle LaRue, and I'm the Director of Health and Human Services at CASA, which is Maryland's largest immigrant advocacy organization. CASA asked the committee for a favorable report on House Bill 588 on behalf of our over 120,000 Black and Latino members who have made access to care our top legislative priority. Of all of the vital services we provide for our community, including education, employment, financial literacy, legal services, by far we touch the largest number of people through our health services. Just in the last year alone, we've assisted over 50,000 Maryland residents with a wide array of health navigation services. Why is this number so large? Our population is largely uninsured and excluded from our formal healthcare system, referring our community members to underfunded and overwhelmed safety net clinics. Maryland has taken great strides in prioritizing health equity and being a leader in embracing reform, as been mentioned by other panelists, yet more still needs to be done to address the lack of access to care for nearly 5% of our population that remains undocumented and uninsured. This bill would help correct that injustice and allow access to the marketplace for all Marylanders, as well as create a framework for a subsidy that would make the plans more affordable. We support this bill with a small but important amendment that is a simple equity measure, and we must find a solution and provide all Marylanders with the opportunity to live in dignity and receive access to the most basic standards of health care, especially as we emerge from a pandemic that saw this population in particular disproportionately impacted. For this reason, we strongly recommend a favorable report on House Bill 588.
Good afternoon, Chair Pena-Melnick and Vice Chair Kelly and committee members, and thank you all for having me here today. My name is Brian Sims, Vice President of Quality and Equity at the Maryland Hospital Association, and on behalf of our 60 hospital systems and members, I'm here proudly to support House Bill 588. I'll be brief. Our hospitals and health systems are strong proponents of the state's efforts to expand healthcare coverage. You all are familiar with our Maryland total cost of care model, in which we are strongly committed to the success of that model, demonstrating that success to the federal government, to our state partners, and to be a model for what healthcare on behalf of the people in the state look like for the rest of the country. And I'll just say that by leaving a large portion of the population out of the opportunity for access to care, affordable access to care, that is incongruent with our goals to achieve the state's population health goals and also the goals of the total cost of care model. This is a population health issue, this is a public health issue, and this is an equity issue. And for those reasons, we support House Bill 588. Thank you.
And if I may for a second, the floor system is down, but they're working on it, okay? So we have the testimony right here. Yeah. You can go back in, log off. It does not affect the hearings, though. Who will be next?
To start us off, Delegate Pena-Melnick, I will be translating.
And for the committee, when we have translation like we did yesterday with the sign language, we cannot adhere to the 2 minutes because it does take time, so we're just a little flexible. So just to let you know, you can go ahead. If you hear the sound, do not worry about it, just finish, okay?
No se preocupe por el sonido, siga.
Okay. Buenas tardes, Buenas tardes, Presidenta Melanie y miembros del comité. Mi nombre es María Teresa Peralta. Soy orgullosamente origen dominicano y hoy vivo aquí en Baltimore con mis 2 niños.
Good afternoon, Chair Pena-Melnick. My name is Maria Teresa, and I am proudly an immigrant from the Dominican Republic. I am now living here with my 2 sons in Baltimore County.
Soy miembro de Casa Maryland, indocumentada y soy sobreviviente de cáncer de mama.
I am a CASA member, undocumented, and a survivor of breast cancer.
A los 32 años me diagnosticaron cáncer de mama triple negativo.
At the age of 32 years old, I was diagnosed with triple negative breast cancer.
Aunque ahora soy sobreviviente de cáncer, para mí no ha sido fácil porque no he encontrado la cura, el tratamiento para sobrellevar el cáncer triple negativo.
Although I am a survivor, it has not been easy for me because I have not gotten or received routine checkups to ensure that my cancer does not come back.
Quizás para los que muchos no conocen, el triple negativo es una de los cánceres más fuertes que hay.
For those of you who may not know, triple negative cancer is one of the most aggressive forms of cancer that there is.
Ahora no puedo llevar tratamiento de cáncer triple negativo porque no hay medicamento para llevarlo, pero sí debo de tener un seguimiento continuo porque es un cáncer que no llega como por... I'm sorry.
Currently, there is no medication or treatment for triple negative cancer, and I am unable to continue with routine checkups.
No es que llega por lo que es, ¿cómo se dice cuando? Es un cáncer que se aloja, no tiene que ver con que sea...
This is a type, she's trying to explain, this is a type of cancer that doesn't recur with symptoms. It can come up randomly. Siga después.
Okay. Ahora debo de tener un tratamiento continuo de seguimiento, la cual no tengo un seguro médico que me pueda dar el seguimiento porque no no tengo a dónde alojarme.
And for this reason, it is imperative that I receive
Los ganglios de mi brazo derecho, todos los ganglios, me hicieron una mastectomía, y lo cual me está impidiendo trabajar.
Unfortunately, I cannot work because due to my previous received treatment, I have no lymph nodes and swollen hands.
Necesito un tratamiento continuo de si mi cáncer llegó, si no llegó, y no puedo porque necesito hacerme los chequeos médicos que necesito. Aparte, tengo mis 2 niños que tienen alergia severa y no tienen seguro médico tampoco.
Because I do not have health insurance, I have not been able to receive that routine checkup that I need to ensure that my cancer doesn't flare up. I also have 2 young kids who are also uninsured and they have severe allergies.
Estoy aquí hoy como persona, como madre, como sobreviviente de cáncer, como una persona indocumentada de Maryland, para pedir su apoyo en este proyecto de ley. Gracias por su tiempo.
So I am here today as a person, as a mother, as a cancer survivor who happens to be undocumented living in Maryland. I ask you for your support of this bill and thank you for your time.
Thank you.
One moment. Gracias por compartir su experiencia. Thank you for sharing your experience. Se lo agradecemos. We're welcome. We're grateful. You're next. Okay.
Good afternoon, Madam Chair, members of the committee. Thank you so much for the opportunity to testify today. My name is Mónica Guerrero Vázquez. I am Executive Director of Centro Sol, the Center for Health and Opportunities for Latinos at Johns Hopkins. I am a public health professional, and I am also an immigrant. Healthcare access is a public health and equity issue. Maryland is one of the most diverse states in our country, and over 20% of Hispanic Maryland residents are uninsured. And that's over 5% of the total population. House Bill 588 addresses critical health disparities, as we just heard, in our state by expanding the Affordable Care Act to all Marylanders, regardless of immigration status. HB 588 establishes a subsidy program to ensure that newly covered individuals have funding to cover their care. We support House Bill 588 because, as we just heard in the testimony before, it improves the lives of our neighbors and Maryland residents like Maria and Julian. Those are 2 couple that we serve in Baltimore. They work full-time, they file and contribute to their taxes. They bought their new house in Baltimore, and they are scared of getting sick. They pray they don't have to go to the doctor. They have heard horror and terrifying stories from people like them who have to pay thousands of dollars because they didn't have health insurance. They have limited to no access to preventative care since they arrived here in the US 15 years ago. Health insurance for them means having access to preventative care, sick visits, timely management of chronic conditions, and ultimately having a healthier life. HB 588 is critical for uninsured, undocumented immigrants and the entire state. It can potentially reduce premiums in the individual market, and having opportunities to keep people healthier is an investment for us. This legislation makes Maryland better, and Central Sol urges the committee a favorable report on HB 588. Thank you.
So this is the end of the sponsor panel. I'm now going to open it for questions, and this is the order that I saw it. First, Delegate White, followed by Morgan, followed by Woods, followed by Taveras.
Thank you, Madam Chair.
My pleasure.
Delegate Cullison and panelists, thank you so much for your testimony. I have a question for Ms. Everly. And so,
You should just stay up.
I was going to say to come up, but I said, I'm going to wait.
So first, I would certainly like to also appreciate and thank this committee for their work on the Healthy Babies Equity Act, as well as your leadership in moving that forward. Can you share how that process has been to apply for the waiver, as well as speak to how the Benefit Health Exchange is prepared to submit this waiver to expand ACA eligibility?
Absolutely. We are in the process right now of, we already submitted a letter of intent to renew our 5-year waiver, and the full waiver will be submitted by the end of March. However, it won't include this piece. This would be an amendment to the existing waiver, and we can do that at any point in time. The good news is that the state of Washington did what we're trying to do, and they did get approved this summer. So we have a roadmap in front of us.
Wonderful. Thank you, Madam Chair.
Thank you. Delegate Morgan.
Thank you, Madam Chair.
My
Just want to
pleasure.
make sure I understand the bill, because this bill would require a federal waiver to allow non-citizens the right to come into the individual market that we've had problems in the past stabilizing. So we worked a few years ago to stabilize the individual market by setting up a reinsurance fund, which was created and funded 2.75% of, what was it, the small group and large group insurance markets? Is that true?
Several things there. When the reinsurance program was set up, the very first year, well, first of all, the federal government gives us a lot of money, and then we have to have a state match. The first year it was a 2.75% assessment on insurers that were already paying that same assessment to the federal government for the federal health insurance tax. After that year, it was waived, and that was why we did it. It was waived, so we took advantage of that. But subsequent to that first year, it was reduced to 1%. The last legislative session, again, it was continued at that 1%. So we have the 1% of funding. Now, what reinsurance covers is the high-cost claimants. And those are folks with real high chronic conditions, lots of times older individuals. So increasing the pool by bringing in additional people is a good thing, because it typically will have younger people, will have healthier people, expands that breadth of how those claims are paid against. So we don't view it as an adverse reaction to the reinsurance program.
I'll allow a follow-up, one.
So, but you could say that you're taxing some people's health care and then providing for health care in the individual market for non-citizens. Isn't that so?
It's a broad-based tax on health insurers, not all health insurers. There have been some carved out of that, and it pays for the entire individual market, whether on exchange or off exchange.
Thank you. I have next Delegate Woods, followed by Taveras, followed by Lopez.
Thank you, Madam Chair. María, soy la delegada Jamila Woods de Distrito 26 del Condado Prince George's. Gracias por tu testimonio. My question is for Dr. LaRue. How many undocumented...
You want to translate that?
Oh, I said to Maria, my name and where I am from and who I represent, and I wanted to thank her for her testimony.
Thank you.
And for Dr. LaRue, my question is, how many undocumented workers currently have health insurance, and where are they getting it from?
It's a very small percentage of our undocumented residents that have insurance because it is so costly to get insurance outside of the exchange. And so you can go to a carrier directly and try to buy insurance, but it is an exorbitant amount of money, and most of our community members just cannot afford that.
Thank you. Delegate Woods, I have to be careful around you when I speak Spanish now. That's a lesson learned. Delegate Taveras, followed by Delegate Lopez.
I should have forewarned you. So, I don't know if I see Mr. Sims. Is he no longer here? Because I did have a question.
Brian Sims.
Or anyone that could speak on behalf of the Maryland Hospital Association?
He left already. Delegate Taveras, who would you like the question? Would you like to ask a question?
Well, I mean, I'll ask the question and see
Yes,
who
please.
best can respond. I would like to know if anyone could speak to the burden on hospitals and how the uncompensated cases of care is reduced through this bill?
So we know about the burden of uncompensated care. We hear about it. You've heard about it through many testimonies and bill hearings this year. And it's, waiting times in ERs. Right there we had a long hearing about that. That's one example. The cost of an ER visit, and I hope that I'm not making this number up, but I have read it's about $5,000 for something that's not urgent. That's not a heart attack, because or something like that. Because people, if they have no options, then they don't know where else to go. So they go to the ED to make sure that, or to get some support, get some help, get some medication. They have a sore throat. That where are they going to go to get that medication? In an ED, they can do that because we have agreed that we won't charge those who cannot pay when they come into the emergency room. So we know that our emergency rooms are overburdened, they're understaffed, and the way that this bill would address that is the reason they're going to the emergency room is because they can't get the preventive care that would be provided under any program that they get with the ACA and any in the exchange, which is the ACA. The ACA, when that bill, that 1,000-page bill was passed in Congress, it focused on preventive care and early diagnosis so that they could deal with problems before they became urgent. And by making that available, making those services available to folks who currently don't have it, will drive down the utilization of emergency rooms, which drives down uncompensated care. Does that make sense?
No, for sure. I just wanted to make sure.
Okay.
I understood. And to Maria, we'll see each other for the cuchifrito. Thank you very much.
Delegate Lopez.
Thank you, Madam Chair, and buenos días a todos. Bienvenidos a todos. There's a couple. Don't sleep on me, Madam Chair.
See, the committee didn't know that you were getting a lesson today, so go ahead. Go ahead, Delegate Lopez.
Thank you. My question is for Dr. LaRue or for Monica. You manage these clinics that are doing very important work, and I thank you for that. Can you explain to the committee a little bit more about the limitations that your clinics have and why it's still important to have this type of insurance for undocumented people?
I'm sorry, someone was talking to me in the back. Can you please repeat the question?
Go ahead.
There we go. Sorry, I pressed it. I knew I shouldn't have. That was the curse. Yes, can you explain the limitations that you have in your clinic work and why it's still important for undocumented people to have this insurance?
Our work is based on public health approaches to preventive care and education for community members to know how to navigate the complex healthcare system, from educating about when to go and when not to go to emergency rooms. Sometimes it's just impossible to not do that. By educating how to contact the financial assistance if there is anything available for them, but also educating people about healthy lifestyles, prevention of type 2 diabetes or healthy weight and healthy eating. Those approaches are important and have evidence base to show that they can work. However, they are very grassroots and they are not billable or sponsored. So we still advocate strongly for healthcare access for preventive care for our constituents.
Any other questions? I don't see none. I do have a few. But Michelle, if I may. Michelle, and I call you Michelle because we're friends, but Miss Eberly. Maryland is unique, isn't it, with our model, our waiver?
Our total cost of care
Yes.
waiver? Yes.
And can you explain to the committee, how does uncompensated care affect our waiver? And where are we regarding the waiver negotiations?
So I can't answer all of that. That's really outside of my sphere of expertise. But I can tell you that we have a contract with CMS that we have to do better than the Medicare averages. And in Maryland, because we have global budgeting for all of our hospitals, that factors into this total cost of care model. So anytime that the hospitals have that increased burden of uncompensated care, that puts pressure on the hospital systems and can affect that total cost of care. And that's about the extent of my knowledge or that I could share with you.
And ED utilization is the biggest driver of uncompensated care, isn't it?
I would expect that to be true. And again, you know, if folks don't have health insurance, the only place to go get, I shouldn't say the only, but the most well-known place to go get care is an emergency room.
And when we meet the requirements of the global budget, we do save money, lots of money, billions of dollars.
I believe that to be true.
Okay, thank you. Seeing no other questions, thank you for your testimony. We do have next Kenneth Phelps, Lead Hudson, Matthew Lopez, and Callie Schamitz. And forgive me if I don't pronounce your name correctly. You can feel free to correct me. Allison Taylor, are you here? Okay, go ahead. Will you be so kind and get started, please? Go ahead. Yes, please.
Yes, I'm Lee Hudson, Evangelical Lutheran Church in America in the state of Maryland. Thank you again, Madam Chair, members of the committee. We're here to support HB 588 because we also advocate for access to appropriate and adequate health care for all people. The reasons we support it are the ones you've heard already from other witnesses at this table. And I'm going to add that this General Assembly has heard for several decades. They have to do with cost, they have to do with outcomes, and from our perspective, they have to do with what is a good society for all of us. So for all of those reasons, we say that this should be a priority for the state to grab another uninsured demographic and see if we can get them to the doctor instead of to the emergency room. And I would add, we would also share an interest in that parity issue and in the aspiration that we might find funding that is adequate to the need. Thank you very much.
Thank you. Who's next, please?
Again, Madam Chair, thank you, and members of the committee. Ken Phelps, the Episcopal Diocese of Maryland. I thank my colleague. I'll say ditto to much of what he said, and the Episcopal Church, again, finds ourselves in complete support of this bill, given our view of healthcare as a human right. But never give a preacher a microphone. And we're in Lent, which is a time of reflection. And this is going to sound odd, but I want to talk about a Senate bill to kind of back into this. And it's Senate Bill 887. And what that bill is asking the MVA to do is develop a special license tag with the motto, "In God We Trust." And you know, that strikes me as interesting because I don't believe it's true. An outside observer to our culture would say, you don't trust in God. You trust in a capitalistic system that is tilted toward the few. You trust in your own portfolios. You trust in your military might. You trust in a proliferation of violence. Those are the things you trust in. Well, Lent gives us that opportunity to really look at, where we are and who we are as individuals. And trust in God is faith in God. Trust in God is trusting that the thing I do with you, the way we interact, the way we engage, has everything to say about who we are. And it really lays the foundation for our future. And that future is all about developing the culture of God again, which is that place where we do embrace each other. We have a moral obligation then to embrace the stranger, to live into the teachings of Christ again as we interpret that within the Episcopal Church. So I guess that's what I'm saying. It's like let's think about that and let's actually prove that we can change this. We can be a different kind of people. We request a favorable report, and thank you.
Who's next?
Hello, my name is Matthew Lopez. Thank you for this opportunity to provide testimony in favor of HB 588 on behalf of the National Immigration Law Center, where I am an attorney and deputy director for state advocacy. We at NILC are an organization exclusively dedicated to defending and advancing the rights and opportunities of low-income immigrants and their families, and are one of the nation's leading substantive experts on immigrant eligibility and access to federal and state health programs. Consideration of this bill comes at a time of significant momentum on state expansion of health coverage, in no small part due to the pandemic. 73% of foreign-born residents now live in a state that offers or plans to offer health coverage to at least some residents regardless of their immigration status. 40 states, including Maryland, cover lawfully present children and/or pregnant people in their Medicaid and Children's Health Insurance Program without any waiting periods. Just these past 12 months have been monumental. In December, the federal government, as you know, granted Washington's waiver to pursue a similar strategy to this and cover individuals up to 250%, FPL in their health insurance marketplace. But they're not alone. Colorado's waiver was also approved, creating a parallel marketplace that is providing 10,000 undocumented residents with health insurance coverage at subsidies up to 300% FPL. Many states now cover older adults and children, regardless of immigration status, in their Medicaid program, and Oregon voters this year enshrined access to affordable care as a fundamental right in their state constitution. California took the monumental step of covering all low-income residents, regardless of status. We are constantly fielding questions about how other states can pursue options like these, and we encourage this committee to provide a favorable report. Thank you for the opportunity.
Thank you for your testimony today. Next, please.
Thank you, Chair Payne-Gamelnick and members of the committee. My name is Callie Shumitz. I'm with the Maryland Center on Economic Policy. We support House Bill 588 because all Marylanders deserve access to affordable health care. And I will echo the comments of folks who have testified previously. And just add that this is a situation where doing something that is good for people is also good for our communities and good for our economy. Affordable health coverage not only improves an individual's health, but health insurance is connected to greater financial security, both by ensuring people are able to keep working and care for their families, and by reducing out-of-pocket healthcare costs. Just for one example, research links ACA expansion with reduced evictions and less medical debt. And as others have noted, we all pay when people in our community delay care because of the and end up with a more serious health condition or end up going to the emergency room. And there are good examples of similar programs in other states. We think it makes sense for Maryland to take this next step. It's a very modest cost to begin setting up the program and apply for the waiver to address Maryland's largest uninsured population and help more low and moderate income families afford health coverage. So we'd ask for a favorable report on House Bill 588. Thank you.
Thank you. Is Allison Taylor here? Len Lucy? Lorraine Aricott? Can you come up, please?
Thank you, Chair Payne-Gamelnick and members of the committee. My name is Lorraine Aricott, Senior Policy Analyst with 1199 SCIU. For 1199 SCIU members, this bill is essential for two reasons. First, our members understand that increasing the number of insured individuals means less of a burden on our short-staffed hospitals. When patients can afford primary care, they are less likely to end up in the hospital. Any step to provide individuals with healthcare coverage to alleviate this strain in short-staffed facilities would benefit both our hospital resources and improve patient care. Second, many of our members come from immigrant families themselves. They know the benefits of what health insurance can do to change the lives of immigrant families and believe that without health insurance, it leaves many Marylanders to a life of increased mortality and family destruction. So for those reasons and for all of the reasons that have been stated today, we ask this committee to give a favorable report. Thank you.
So this is the favorable panel. We have the next panel, favorable with amendment. Before I call them, the witnesses that were here, can you come back in case there are questions? Are there any questions for the witnesses? You can come back to the seat, please. Thank you. Just pull a chair. Thank you. I have Delegate Chisholm, followed by Delegate Lewis. Okay,
Thank you, Madam Chair.
my pleasure.
And once again, my question's for Pastor Ken. I've been on this committee for 5 years, and I think most people that have served on this committee with me will attest to you that I've never ever said anything disparagingly about somebody that's come over here across the border illegally, because I understand why they want to come here. And it's precisely because we're one of the most giving, compassionate countries in world history because we have a capitalist society. If you don't believe that our capitalist society is caring, why did we have 5 million people come across the border into this country in the last couple of years? And if it's so horrible, why aren't people going back across?
Difficult question to answer, but I would say just historically, when you look at other empires, the Roman Empire was finally undone because they had stripped the resources of all of the countries out beyond them. They existed on the boundaries and brought everything in. And their immigrant population swelled because that's where all of the wealth went. And if you look at our policies in Central America alone, just in the 20s and 30s, again, it's banana republics. It's just stripping away of the resources, and of course they're going to follow the money. If Nike would pay, that old example, a nickel an hour for a factory worker in Mexico when they knew they could make minimum wage up here and send that money back, what would you do?
Okay, thank you. Delegate Lewis.
Thank you, Madam Chair. Thank you to this panel. My question's for Mr. Lopez. You listed a few other states that have used different models for expanding health insurance coverage to undocumented residents, but I wanted to make sure I understand the difference. We're looking at using our health exchange. You said other states had taken different strategies. Could you talk a little more about that?
Sure. So there's, I would say, probably 3 main strategies that you can take in expanding coverage to folks who are excluded from federal programs. One of which is, and it sort of builds on the existing federal framework, one of which is the Medicaid framework. So every state creates their own Medicaid program, and they can create, if they use their own state funding, they can create additional categories beyond the federal requirements. You can cover higher income limits and such. Some states have taken that to cover children, to cover older adults, especially, are becoming a growing trend across the country. So you can use that. You can use this model, which is sort of building upon the Affordable Care Act model, which is how to use the private marketplace in order to expand health access to cover additional people. That's a little bit more scalable. You can have varying, you can set different levels. You can and you improve in many ways the marketplace, as the executive director of the marketplace was discussing. And the third model is through lower level, like individual community focused approaches, which tend to be more limited and county based, which end up being putting a lot of strain on local government. So we find many times a state government is much better suited to create a system for the whole state.
Indulge me with one follow-up question.
One.
Thank you. So if we use the Affordable Care Act health exchange mechanism, the principle of that is it's a qualified health plans that individuals pay for, which is different than Medicaid. Although there are co-pays and there may be various out-of-pockets with Medicaid, but the health exchange involves folks paying for coverage. So just to make sure I understand, we're creating an opportunity for more people to get coverage, but they still will be paying a part of that coverage.
You are largely going to be correct in that currently people who are undocumented are not eligible, even if they can afford to pay for the entire health plan. They are not able to use the exchange to purchase their health care coverage without a waiver because of federal restrictions. So you would have some people who are, you have varying degrees of income for folks who would be purchasing. So some people will be paying, could be paying up to the full amount. Some people would be paying an amount based on the subsidies. But it is different from the Medicaid system, where there would also be cost-sharing elements of it, more so than you would have in Medicaid. So yes, this is not as much of a government-funded program as a Medicaid system would be. I'm not quite sure I would call Medicaid a giveaway, but I would say that it requires more sharing of cost.
To clarify, you have to pay for it.
For Medicaid?
No, you have to pay, when you go into the exchange, you have to pay for the insurance.
Yes, some individuals may qualify for subsidies that cover the cost of their insurance, but there would then be more things like copays and other cost-sharing elements of a plan on the marketplace.
Right, but what the bill does, just for clarification, and correct me if I'm wrong, is that presently, people that are not here legally present are not allowed to purchase insurance from the marketplace, correct?
Correct, Delegate.
And the marketplace, the Maryland Health Benefit Exchange, is the place where the people in Maryland can go and purchase insurance. And they do their homework, what are the best prices out there, and they compare and screen you, correct?
Yes, that is correct. It would allow undocumented people to purchase. It would create an opportunity to purchase healthcare insurance, including many people who may purchase it at full cost.
That's right, but they're not able to apply for Medicaid.
That is correct.
Right. Thank you. And in order to be able to purchase, they need, because it's you get federal subsidies, you need permission, and the only way to do it is by getting this amendment that other states have gotten.
Even with yes, correct. Even without receiving subsidies, it requires permission to change your marketplace. So that is correct.
Thank you. We have, if I may, Delegate Morgan. And thank you for your patience.
Thank you, Madam Chair. Quick question for anyone on the panel. So we understand this, and I think it piggyback off of what the chairman just said. So if you're a non-citizen, you can buy insurance on the private market. This is to allow you to buy insurance into the individual market, which the entire market is subsidized. I mentioned that earlier in the question with the reinsurance program. My question is for you is how much money, total taxpayer money from the federal government, from the state government, flows into the individual market? How much is it subsidized?
I think if the executive director of the marketplace is here, she may be able to answer the second part of your question. I would also, though, note in the first part of your question about purchasing insurance, theoretically, there is the opportunity to find a broker who is able to sell a person an insurance plan. However, it is often in practice extremely difficult for a person who is undocumented to find a way to enroll in a health program through private insurance, because many of them will require things like a social security number. So from a practical standpoint, this creates a more practical ability to allow people to enroll in health insurance, and also has the added benefit of, as was discussed, in improving the pool that benefits all residents of the state.
And if I may ask,
Thank you,
Michelle,
Chair.
since you're not not up to testifying because we called you already, can you submit the information requested by Delegate Morgan to council and to the whole committee, please? Thank you very much. And also the report that you did of the uncompensated care report, if you could send it to the whole committee. Thank you. Delegate Shalega.
Thank you, Madam Chair. I
pleasure.
don't know if this is the right panel to answer this, but if not, we'll get Michelle to send us a report. So this bill will allow undocumented immigrants to get access to the health exchange, which is subsidized, and to prove the income, they use tax returns. So how can we verify those tax returns are accurate, and can undocumented immigrants file a tax return? So I'm worried about subsidies being granted with fraud, because we know there's a lot of fraud in all of these systems.
So I'm not as familiar with the process of how income is verified. That would be a better question. But as far as tax returns, many immigrants in Maryland pay taxes. They file tax returns using an individual taxpayer ID number. If they don't have a social security number, they file and pay state and federal taxes. It's hundreds of millions of dollars a year. To the question, the point earlier about these are taxpayer-funded programs. The people who would be benefiting from this are also paying taxes, just like the rest of us.
Sometimes they have more benefits than they pay in taxes when they're low income. So with education and healthcare, and so, but verifying that, Michelle, if you could let us know, that would be good. Thank you.
And Michelle, you can work with the controller's office. There's a report that 89,000 ITIN holders the year before last pay only Maryland taxes, $140 million. People that submitted their paperwork properly and pay taxes to Maryland. So if you can give that information, and I see the Latino caucus here too. There's a report on that as well. If you can submit it to the committee, I think it's great information. Thank you, Delegate Shalega, for the question. Any other questions? Delegate Hill.
Thank you, and thank you for being here. Just to clarify, if I'm a I-10 filer and I work, which is why I'm having my I-10, I'm paying my Social Security, and my employer offers insurance, can I get insurance through my employer?
Employers can provide insurance to all employees. There are no immigration restrictions on employers' ability to provide health insurance to their employees. Now, that does not necessarily mean that many employers that may employ folks that are in that situation offer that insurance, but there is no federal restriction on them doing so.
I understand you correctly. There is a way for people to do the right thing as employers and make sure that these employees get benefits. And so we're just trying to make sure that the undocumented folks who don't have those kinds of employers also have access to the health care they need so that they don't end up in emergency rooms and costing all of us a lot more money. They can frankly just get the health care they need because it's the right thing to do.
Yeah, that's accurate, I believe.
I see no other questions. Thank you so much for being here with us today. For those of you that we have requested information, please be so kind to follow up with the delegates, okay? Thank you. Next, we have Jeanette Keene, Stephanie Clapper, Michael Patty, Anna Rubin, and Nelly Campos. And then for the committee, after those witnesses, we're going to go virtual with a couple more witnesses, okay? Thank you, everyone, for being so patient. We really appreciate it. Will you please get started?
Hi, I'm Stephanie Clapper, Deputy Director at Maryland Healthcare for All Coalition, and thank you for this opportunity to testify in favor with amendment of House Bill 588. I'm testifying on behalf of Len Lucci as well. Under this committee's leadership, we have made great progress in Maryland. Over 400,000 Marylanders have gained coverage under the Affordable Care Act, and we've made progress towards health equity through bills like the Healthy Babies Equity Act and the Health Equity Resource Act. But we must do more. We're still at 6% uninsured in Maryland, and we want to get to 0%. I am here on behalf of the over 300 faith, business, labor, community, and healthcare organizations from across the state that all stand towards quality, affordable health care for all Marylanders. And by all Marylanders, I do mean all, regardless of immigration status. It is a tragedy that so many of our friends and neighbors are precluded from getting access to affordable health coverage simply because of their immigration status. Expanding access to coverage will help improve health equity, as disparities in access to coverage for Black and Latino Marylanders have improved, but still are not where they need to be. Black and Latino Marylanders are sicker, hospitalized, and die younger than other Marylanders. In addition to this being a matter of justice, this legislation would help all Marylanders through reducing uncompensated care. As others have said, when Marylanders don't have access to the health care they need, when they need it, their conditions often worsen to the point that they have to go to the emergency room. And then all Marylanders pay for that through our increased premiums because of the way that our hospital payment system works. We are in favor of the amendment to make sure that any subsidy program would work so that undocumented immigrants get the subsidies at the same level as any other Marylander. Thanks to your committee's leadership, Maryland has one of the top 5 healthcare systems in the country, and I urge a favorable report on House Bill 588 so we can continue to lead.
Next, please.
Thank you, Chair Peña-Melnick and Vice Chair Kelly and members of the committee. My name is Anna Rubin. I live in Columbia in District 13. I'm testifying in support of House Bill 588 with amendments on behalf of Jews United for Justice, which organizes 6,000 Jews and allies in support of social, racial, and economic justice campaigns in Maryland. The issue of ACA inclusion for people, regardless of immigration status, is personal for me, as I've detailed in my written testimony. In the past 6 years, I've worked with a refugee family of 7 who came from Syria in 2016 after years in a Jordanian refugee camp. They were given Medicaid immediately as part of their federal benefit package. The care they received was crucial because they'd gone several years without. Health care has been vital as their children dealt with a slate of childhood diseases, the mother went through pregnancy and childbirth, and the father dealt with serious chronic back injuries. The parents have found jobs and resettled successfully. They couldn't have done this without good health care. Including undocumented people in the ACA is not only humane, it helps prevent the spread of infectious diseases, maintains a healthy workforce, and saves money by reducing the reliance on ERs. As Jews, we are obligated by our ethical tradition to make sure that all are treated as sacred human beings, deserving good health. On behalf of JUFJ, I respectfully urge you to return a favorable report on HB 588 with an amendment that ensures newly qualified individuals will receive the same subsidy rate as all other individuals covered under the ACA. Thank you.
Yeah, who's next?
My name is Janet Ken. Good afternoon, Chairwoman and members of the committee. I am here today as a Cameroonian immigrant and a proud resident of Prince George County. I am undocumented, and for years, I have had a series of health issues that have held me captive for years, from diabetes to blood clot in my lungs, to painful issues with my lower leg. I have had restless days and nights for a long time as I can remember. Sickness does not discriminate. Sickness does not care about your immigration status, but our healthcare system does. And we have been excluded and left behind for too long. 3 days ago, I was rushed to the emergency room in Washington, D.C. hospital. Because I did not have insurance, I spent 12 hours in the hospital with no assistance. I can't begin to describe the pain, trauma, and emotional stress I go through every single day. My health is so bad, and I don't know what awaits me. I know that my children will not grow up seeing me because I don't have insurance to get a good treatment. I have 7 grandchildren. I want to see them grow. I self-medicate. Google is my doctor. Delegates, I implore you to vote yes to the HB 588. Please support us in this fight for access to healthcare so that people in Maryland will have a reduced mortality rate and good health. Please, thank you.
Thank you for sharing your stories. We really appreciate it. Who is next?
Thank you, Madam Chair. Michael Patty here with the Maryland Dental Action Coalition, just to remind the committee of the importance of oral health care. Currently on the exchange, there are standalone dental plans in addition to health insurance plans. The way the bill's drafted, we just feel that standalone dental plans aren't included in the initial draft. I know we've reached out to Delegate Collison to see those included. I did want to highlight that the Washington waiver and is reflected in the fiscal note did include standalone dental, so we would just see that that amendment would get added to the bill. Otherwise, it's a great bill, and the Dental Action Coalition's in support. Thank you.
Who's next?
Chairwoman Peña-Melnick, I will be translating again as well. Thank you. Yes.
Buenas tardes, Presidenta Peña-Melnick y miembros del comité. Mi nombre es Nelly Campo, tengo 47 años, soy de El Salvador, vivo en el condado de Howard, en la ciudad de Columbia. He vivido en este país 19 años.
Good afternoon, Chairwoman Peña-Melnick and members of the committee. My name is Nelly Campos. I am 47 years old. I am from El Salvador, and I live in the city of Columbia in Howard County. I have lived in this country for 19 years.
Durante todo este tiempo no he tenido acceso a un seguro médico por mi estatus migratorio. He sentido tristeza, pena y miedo, porque el solo pensar de ir al médico me viene a la cabeza una gran deuda y me pregunto, ¿cómo voy a pagar? Porque los biles son altos en comparación a mis ingresos. Digo esto porque una vez que fui a que me hicieran una mamografía, porque tenía mucho dolor, me cobraron $400 aparte de la consulta y además solo me dieron medicina para el dolor, Tylenol o ibuprofeno.
During all this time, I have not had access to health care due to my immigration status. I have felt sadness, sorrow, and fear. Just thinking about going to the doctor, a great debt comes to mind, and I ask myself, how am I going to pay? I know that medical care is so high compared to my income. I say this because once I went to have a mammogram checkup due to a lot of pain I was in. I was charged $400 in addition to the consultation fee, and ultimately all the care I received was pain meds, Tylenol or ibuprofen.
El saber que hay una posibilidad de acceso a la atención médica sin importar el estatus migratorio y a bajo precio, o sea, según mi ingreso, para mí sería como vivir con alegría, en paz. Por supuesto que me haría los chequeos preventivos que toda mujer debe hacerse para prevenir enfermedades graves y estar saludable para seguir trabajando.
Knowing that there is a possibility of access to care regardless of immigration status at a low price, that is according to my income, for me, it would be like living with joy and peace. I would finally receive the preventative care checkups that every woman should have to prevent serious diseases and be healthy to continue working.
La comunidad inmigrante también aportamos al Estado con nuestro trabajo y impuestos. Delegados, apóyennos y ayúdenos a que se pueda, a que se apruebe la ley de acceso a la atención médica para todos.
The immigrant community also contributes to our state with our work and our paid taxes. Delegates, please support us by helping pass the Access to Care Act for all. Thank you.
Gracias por compartir su historia. Thank you for sharing your story. Are there any questions for this panel? Delegate Lewis.
Thank you. Thank you, Madam Chair. Thank you to the panelists. Muchas gracias para compartir su historia. Madame de Cameroun, je vous souhaite bonne santé.
Merci beaucoup.
Et merci de partager votre histoire. I want to just make sure folks know they cannot mess around in this committee. But for the gentle lady from Cameroon, and what I said was thank you for sharing your stories in 2 languages. For the gentle lady from Cameroon, I would like to understand a little bit better, as a person from another country who is also a person of African descent, I'm curious to know more about the different challenges you might have faced in accessing care, because we know there are layers of obstacles, and I'd like to know if you've experienced additional difficulty because you are a Black person in this country.
Thank you for the question. I have been in this country for 20 years, but I fell sick 7 years ago. During that 20 years, I was working hard. I do all sorts of odd jobs, cleaning people's houses as an immigrant, doing their landscaping, roofing. I can show you, I can name as many jobs that I have done in this country. And during that time, I was paying my taxes. I got coverage in Montgomery County because where I live, in Tacoma Towers, that complex is between 2 counties. So it depends on the person who is on the computer. He can put me either in Montgomery County or in PG County. That's how I got coverage in Montgomery, because the person who was on the computer saw that I live in Montgomery County, Tacoma. But 2 years ago, they discovered that, okay, somebody just came in and saw that I live in PG, and they took off the coverage. So since 2 years, I have not got coverage. I've been sick. I have a venous stasis. I had blood clot in my lung, which that time I didn't have coverage. I went to Adventist Hospital. The bill came up to $63,000. I couldn't pay, so I had to go to the natural way, drinking herbs, seeking help from Google. I go to Google, I ask how to treat blood clot naturally, and they give me some solution. I try to do like that at the point that the blood clot disappeared, but the remaining one is calcified. At the present moment, I have a calcified granuloma in my lung. The doctor told me that one will not kill you. I said, okay, I believe you. After that, it was pleurisy. Pleurisy, why? I don't know. The condition, the climate, I still beat it up, but diabetes has been at the top. That I have tried. My sugar was at 385. I was about to go into diabetic coma when they discovered there is no diabetic patient in my family. So I have been fighting. One morning I woke up, I saw just my legs swelling. I said, what is this? I went to a clinic at Langley Park. They told me, you have diabetes. I started doing what I can do, searching, doing my own research on herbs. I go on YouTube, I look for those who have had that sickness before me and what they do and what they did. So I try to copy what they are doing. And to come back to what your colleague asked, why do immigrants come to this country? And when they don't find a way, why do they not go back? I am an immigrant. Before I came to this country, I have a bachelor's degree in my country. Because of the political situation, I have to run away. My children are scattered in different countries. I came here, I applied for asylum. And the judge just looked at me and told me, you were rich back home, you must have. I said, no, I was not rich. I was struggling to survive with my children. I have 7 grandchildren. I've worked hard to bring my two children up. The third, I had 3 children. 1 died, leaving four children. So I'm the one who have been taking care of them because my 2 girls cannot take care of those 4 children. They have their own. When your colleague asks that, why can we not go back? If you fall sick today, anybody in this hall, you fall sick, you go to the hospital, it's an immigrant who will take care of you. If he has become a citizen in this country or he's working, most of the hospitals are full with immigrants. They were immigrants, they were undocumented before they had their papers. So it's a process. But one day I believe I will have my papers. I have been in Tacoma Towers for 20 years, from 1 bedroom to 2 bedroom, from 2 bedroom to 3 bedroom. I'm not going anywhere, or either I die there.
No, we do not do that.
In the same apartment.
One second.
I haven't changed my apartment.
Ma'am, hold on 1 second. We do not do that. We always keep the decor, okay, in the committee. Thank you. Go ahead.
Yeah. I have lived there for 20 years. When I took an apartment of 3 bedroom, this is 16 years that I'm in that apartment because I love PG County, where I live. I don't drive, and because of my situation, I cannot live far from the main road where I can catch my bus. I escape. Even with this foot, 2 years ago, I was doing roofing in somebody's house, but he didn't know that I had a sore on my leg. I can show you the pictures. I did it. I struggled. Before I go to work, I take painkillers. I take ibuprofen. Just to calm down the pain, I go and look for the small dollar that I will feed my children and my grandchildren.
Okay, thank you. Thank you very much. Are there any other questions? All right, thank you so much for your personal story. We really appreciate it. We really do, okay? And the committee's listening. And we thank you for your time, everyone, regardless of where you are on the issue, okay? We're very respectful. Thank you. May we please go to the virtual testimony? And will you be so kind and allow everyone to come in? Thank you. Good afternoon. Will you be so kind and get started? Thank you very much. Let's start with Mr. William Reed.
Yes, can you hear me okay?
Yes, we can.
Yes, good afternoon.
And thank you
Madam-
for your patience. Go ahead.
No problem. Good afternoon, Madam Chair and members of the.
Good afternoon. Will you
members.
be so kind and get started?
Yes, can you hear me?
Thank you very much. Let's start with Mr. William Reed. Will you be
Yes.
so kind and you must mute your computer? I mean, excuse me, the link, you have to shut it off. Now listen to the hearing so that we don't get the feedback, okay?
Okay, good. I'm
Thank
ready.
you.
Yes, good afternoon, Madam Chair and members of the Health and Government's Operation Committee. I am Dr. William Reed, and I live in Frederick, Maryland. I am a leader with Progressive Maryland Healthcare Task Force and Frederick County Progressives. I am also a member of RISE, Western Maryland, which is Resources for Immigrant Support and Empowerment. Thank you for this opportunity to testify in support of House Bill 588, the Access to Care Act. I urge your support for the Access to Care Act, which will allow Maryland Health Benefit Exchange to cover all Marylanders who meet the Affordable Care Act eligibility requirement, regardless of their immigration status. The Access to Care Act provides a way to address the racial disparities in our healthcare system, so allowing access to the exchange for Marylanders of color who cannot currently make use of it makes sense. I'm a retired veterinary staff scientist from the National Institutes of Health, and I have worked in infectious diseases research for more than 30 years. I am also a member of the Frederick County Health Department's COVID-19 testing task force, charged with community engagement and ensuring that our residents, especially those in vulnerable communities, have access to free COVID-19 testing. My background and my experiences during the pandemic have made me keenly aware of the insufficiencies of our healthcare system, especially when it comes to meeting the needs of our neighbors who are undocumented immigrants. I urge you to pass House Bill 588 and support the state subsidies program for those individuals and families who will be enrolling. These subsidies will help ensure newly eligible residents register and get the medical care and attention they need when they need it. Thank you, and I appreciate your consideration.
Thank you. Any questions for this witness? Seeing none, thank you very much. Next witness, please. Mark Israel.
Hi, thank you so much, Chair Pena-Malink and Vice Chair Kelly and members of the Health and Government Operations Committee. My name is Mark Israel. I am a rabbi and a resident of District 19, so glad to be here supporting Delegate Cullison's bill from my home district. And so this testimony is in support with amendments of HB 0588, Access to Care Act. I'm a first-generation American on my father's side, and I know the struggles that my father and his parents went through when they moved to this country. And as I indicated, I'm also a rabbi here at Tikvat Israel Synagogue in Rockville, a small congregation where we're not able to provide a full health care plan. Last year, when my wife needed to switch jobs and we had to go out and get health insurance through the Maryland Exchange, I was impressed with the quality and quantity of options available and grateful that we were able to find a plan that meets our needs. But we also recognize that we live in Rockville, an area with many recent immigrants, many of whom don't have access to the health exchange because of their status. Passing the Access to Care Act will give these families the same opportunity for healthcare that I was able to get for my family. As a rabbi, I often teach my community that in the Talmud, the rabbis talked about how all communal leaders must provide health care and other essential services for non-citizens at the same level that they provide them for citizens. The text explains that we do this for the sake of shalom, for peace, which comes from the same Hebrew root as the word shalem, wholeness. Passing the Access to Care Act is an important opportunity to make our communities whole, allowing every Maryland resident equal access to health care. The current bill, HB 0588, with its Senate companion SB 0365, would open the Maryland Health Exchange to the 275,000 undocumented immigrants in Maryland, reducing emergency visits and mortality rates, as well as increasing the rate of early detection and improving long-term management of chronic disease and serious illness. Throughout the COVID-19 pandemic, Maryland has been a leader in our nation enacting science-based, sensible healthcare measures to prevent the spread of the virus. At a time when many states are mistreating immigrants through cruel and bigoted means, Maryland once again has an opportunity to be a leader and to live out our values of welcoming the stranger by ensuring that everyone has access to health care. I respectfully urge this committee to return a favorable with amendments report on HGO 588.
Thank you very much for your testimony. May I have Ms. Elizabeth Chung? You can unmute yourself, please. Thank you.
Good afternoon, Madam Chair and members of the committee. My name is Elizabeth Chung. I'm the Executive Director for the Asian American Center of Frederick. I support House Bill 588, Access to Care Act. I was an immigrant for about 50 years and lived in Maryland for 30 years. 100% of my time has been focused on health equities. And I'm so proud to be serving actually all three administrations since then. So as a nonprofit organization, we address health disparity. I have extensive experience in working for the underserved and uninsured and also undocumented clients. For the past 4 years, AACF has been part of the Community Health Access Program in Kaiser Permanente to provide health insurance to thousands of Marylanders. For every person we enrolled in Frederick, there were about approximately 2 people placed on the waiting list. However, despite Kaiser's generosity, there are still access issues because many of our clients in the community from Western Maryland lack adequate transportation to access health care. So House Bill 588 would remove those barriers as tens of thousands of residents would be able to access healthcare services in their own communities. Another observation I make is that in 2021, almost 90% of my applicants were in households containing more than 2 members. 20% of those households, both parents work, and 41% only the person working is really female. And also that so 60% of those households, childcare is an issue. And there's also gender gap. The female was only making $14.27, while the male is making $19.27. As you can see that one other issue is that they peak at between 41 and 45. My point is that our families are not able to afford those to help the financial support to support the subsidy for this program. Thank you very much for your time.
Thank you. We have next Ria Aurora, followed by Frank Patinella.
Good afternoon, Madam Chair and Madam Vice Chair and members of the committee, and thank you so much for giving me the opportunity to testify today. My name is Ria Aurora. Though raised in California, I moved to Maryland in 2018 and lived there for 4 years while attending Johns Hopkins University. While at Hopkins, I spent 2 years as a patient advocate in a pediatric clinic, connecting uninsured Latino families to resources related to social determinants of health. Last year, I moved to Washington, D.C., and I now serve as an AmeriCorps Fellow at La Clínica del Pueblo in the Gender and Health Program. I connect Latino women who are survivors of gender-based violence to community-based resources, legal, and medical services. This year marks my 3rd year supporting Latino communities in Maryland. After my fellowship, I will attend medical school this fall. La Clínica del Pueblo is a federally qualified health center that has offered health and community services since 1983 in the Washington metropolitan area, with one location in Hyattsville. Our mission is to build a healthy Latino community through culturally appropriate health services, especially for those most in need. Today, I would like to speak about the lack of healthcare coverage for Latino immigrants in Maryland, as I witnessed firsthand these adverse consequences. At Hopkins, I remember assisting a 45-year-old uninsured female immigrant when making a dental appointment, having already had several teeth fall out. At La Clínica, I continue to see these disparities with my clients in Maryland, who already deal with the effects of trauma, given that they are survivors of gender-based violence. I'm currently working with a 26-year-old uninsured female immigrant experiencing a high-risk pregnancy. In a recent call with the hospital, I was told that because she has no health coverage, the surgery she might need would cost $50,000. Hearing these stories, especially with the potential of this bill, has mobilized me to challenge the status quo and take action by testifying before you all. Today, I respectfully urge a favorable with amendment report of the House Bill 588 Access to Care Act. For the purposes of equity, La Clínica del Pueblo supports an amendment that assures newly qualified individuals will receive the same subsidy rate as all others under the Affordable Care Act. As an incoming medical student and future physician, I want to practice in a workplace who do not have to sacrifice their right to health care to maintain their quality of life. Thank you for your consideration.
Thank you for your testimony. Next, please.
Madam Chair, Vice Chair, and members of the committee, good evening. At this point,
My name is Frank Patinella, and I'm a senior policy advocate with the ACLU of Maryland. We support this bill because we believe that access to care is basic and fundamental human right. Knowing that I have access to care for my own family means security. Access to care means longevity. Access to care means financial solvency. Access to care means opportunity. And access to care means freedom. These are principles and values that we as Americans pride ourselves on. And I want to take just a moment to explain how this has impacted my own life. My parents were both immigrants, and growing up, I watched my father suffer with chronic illness of type 1 diabetes. I've seen him have reactions to his condition, shaking and in a state of confusion. I remember him having to go to the doctors frequently and a few times to the emergency room. Access to care saved his life, and not only that, it allowed him to have opportunities, and consequently, I had that growing up. We were never saddled with debt because of his condition. He ran a successful business and was able to provide for us financially and contribute to the tax base here in Maryland. I can only imagine what would have happened if he didn't have health insurance. Perhaps his condition would have spun out of control, he could have slipped into a coma, or perhaps it could have been fatal. Perhaps I wouldn't have been able to go to college or be standing here now, able to provide for my own family. If we want people in Maryland to be healthy, take care of their families, pursue opportunities, and contribute to the tax base and make our state economically stronger, then please vote yes on access to care. With the CASA amendment, thank you.
Thank you. Kate Sugarman? She's not here? She's not there? Okay. Next, we have, she's not here. How about Margarita Gallegos?
I'm here.
And the translator?
Yes, please.
Who's the translator?
I'm here.
Sebastian? Wonderful. So we're going to start. Do not worry about the timer, because I know it takes a little longer. Margarita Gallegos, puede empezar. You can get started.
Gracias, estimado presidente Peña Melkin y miembros del comité. Buenas tardes.
Dear Honorable Chair Peña Melnick and members of the committee, good evening.
Soy Margarita Gallegos y vivo en Frederick, Maryland, Distrito 3. Tuve el honor de reunirme con el delegado Kern el lunes por la noche a discutir este proyecto de ley en nombre de la coalición de Justicia para los Migrantes Rights en West Maryland. Nos complace apoyar la HB 588 con enmiendas.
I'm Margarita Gallegos, and I live in Frederick, Maryland, in District 3. I had the honor of meeting with Delegate Kerr on Monday night to discuss this bill in person. On behalf of the RISE Immigrant Justice Coalition in Western Maryland, we are pleased to support HB 588 with amendments.
Aunque Maryland ha ampliado el acceso a la atención médica, la comunidad de inmigrantes se ha quedado atrás. Más de 300,000 de nosotros no tenemos seguro médico.
Although Maryland has expanded access to health care, the immigrant community has been left behind. Nearly 300,000 of us don't have health insurance.
Dentro de este caso está mi madre, con quien yo luché por muchos años, muchos meses, buscando una cobertura médica para que ella pudiera tener un trasplante de órganos, ya que ella tenía el donante, pero el seguro que ella pudo conseguir o yo pude ayudarle no cubrió los gastos de antes y después del trasplante, así que solo pues le cubrió la diálisis. Ella murió hace un año y a pesar de tener su residencia permanente en los Estados Unidos, pues ella nunca pudo tener una cobertura digna de cubrir todo lo que ella necesitaba.
I have family members who are included in those 300,000. Experiences like the case of my mother. I was with her for months as she fought for her life and for health insurance that would cover her organ transplant. She had the donor, but the insurance I was able to get for her eventually only covered her dialysis. She died 1 year ago, and despite being a U.S. resident, permanent resident, she could not have access to the insurance with full coverage that could have saved her life.
Luché con ella con muchas citas, social service, diferentes lugares que me decían que yo podía ir con ella para poder encontrar un seguro médico para ella, pero definitivamente nunca fue posible.
I fought for so many appointments over and over, talked with so many doctors to be able to track down insurance. for her and was never able to.
Igual el caso de mi sobrino, a consecuencia del encierro que tuvo en la pandemia, él pues está teniendo dificultades mentales y pues hasta ahora no hemos podido encontrar un seguro que sea accesible y que le pueda cubrir las necesidades que él tiene a pesar de que él es un dreamer.
Another case in my family is my nephew, who, as a result of confinement during the pandemic, is having serious mental health challenges, and he has not been able to receive the care that he needs because he lacks affordable insurance. And he is a DACA recipient. He is a dreamer.
Gracias de nuevo y pido en nombre de mi comunidad inmigrante un informe favorable con una enmienda que garantice que recibimos los mismos subsidios. Si no es alcanzable, no es accesible.
Thank you again, and I ask for a favorable report with an amendment that we receive equitable subsidies, same as those who are currently eligible. If it's not affordable, it's not accessible.
La cobertura a los inmigrantes independientemente de su estatus migratorio, pero no Maryland, ¿por qué no?
Other states are extending coverage to immigrants regardless of their immigration status, but not Maryland. Why?
Los inmigrantes hacemos profundas contribuciones culturales, sociales al Estado, al país, y muchos de nosotros somos trabajadores esenciales que mantuvimos este Estado arriesgando incluso nuestras vidas durante la pandemia. Contribuimos con millones a través de impuestos federales, estatales y locales, y somos seres humanos. Entonces, ¿por qué no vale la pena proteger a nosotros y a nuestros hijos?
This is the final line.
I was going to ask you to wrap up, so that's great. Go ahead.
Yep. Immigrants make profound cultural and societal contributions to the state and country. Many of us are the essential workers that kept the state going and risked and even lost our lives during the pandemic. We contribute millions through federal, state, local taxes, and most importantly, we too are human beings. So are we and our children not worth protecting? Thank you.
Gracias. Thank you. Are there any questions for these witnesses that you have in front of you virtually? Seeing none, thank you. Muchas gracias. Thank you for waiting, okay? I know it takes a while. We have, there's no one else? Almirca de Leon is not on? There's no one waiting on Zoom? Okay. No one else is waiting on Zoom. These were the last witnesses. There are no more questions. I want to thank everyone for your patience. I know it's been a late afternoon for your testimony. And this concludes the bill hearing on House Bill 588. Thank you very much. Excuse me? You owe me 2 dinners.
It might need to be a drink.
Delegate Collison owes us 2 dinners. Oh, 1 second. The weekly review meeting, if you could go to your offices and come back in like 15 minutes or so, that would be wonderful. So that's Delegate Morgan and Delegate Kipke and the chairmen of the subcommittee. You could go to your offices for 15